Deep from Delhi, and I welcome you all to our this session of Teachers of Tomorrow. And I just want to mention to all candidates that how do we score, how do we give the numbers? It's a content of 4 marks. We have to check the contents, how exactly is the content original or what is the quality of contents. Secondly, the speaking skill, how fluently or fastly you are speaking, how confident are you in your paper and your things, and how you finish in time or not. So your timing, they have not mentioned what is the time. 4 minutes. So be in time and how you answer the question if anybody question arises. Okay. So I call first Dr. Geeta Behra. Is she there? I have this paper actually. No, this is incomplete. You want to go first? Okay. You come first. Okay. Dr. Prasanna has requested to come first because he has another commitment. In,
Is it audible? Okay. Sir, 4 minutes. 4 minutes. Sir, okay. Good afternoon to everyone present here. My topic is on approach to a case of dyschedema, and we are team Retimurable. So before we start dyschedema, there are a few terminologies I'd like to discuss. So there are two terminologies called true dyschedema and pseudo dyschedema. Under true dyschedema, we have papilledema and true dyschedema. Papilledema is due to raised intracranial pressure, and dyschedema is just causes other than that of raised intracranial pressure. And pseudo dyschedema is elevation of disc, which is not due to an axonal swelling. So I'd like to put forward 4 steps to approach a case of dyschedema. The first step is to identify whether it's a true dyschedema or it's a pseudo dyschedema. So there are certain signs to help us identify what is a true dyschedema. We have 5 mechanical and 5 vascular signs. The first is elevation of optic disc, blurring of disc margins, filling in of the optic cup, edema of the RNFL layer, and folds, that is Patton's lines and choroidal folds. Vascular signs will include hyperemia of the disc, venous congestion, peripapillary hemorrhages, exudates, and nerve fiber layer infarcts. Whereas to identify a pseudo-dyschedema, it's just contrary. There will be an yellow disc with sharp optic disc margins, smaller absent optic cup, and no folds. There will be SVPs which are present, normal small vessels, no telangiectasic vessels, transparent RNFL, and there will be absent RNFL hemorrhages. And it is usually bilateral in presentation. So we'll just get pseudo-dyschedema out of the way. So the common causes are optic disc drusen. We get a lumpy, bumpy appearance on OCT. We also have tilted disc anomalies, morning glory syndrome, and myelinated nerve fiber layers. Other causes will include Bergmeister papilla, optic disc hypoplasia, congenital crowded disc, and vitropapillary traction seen in PVDs. So step 2 is to evaluate the case of a true dyschedema. So once you find out there is a dyschedema, you will go detailed into the history. You will check the BCVA, RAPD, color vision, blood pressure. You will assess the fundus for any other etiological clues, visual fields, and OCT-ONH to confirm the diagnosis. And do not forget to check the other eye. So the step 3 is to establish whether it's a unilateral or a bilateral dyschedema. So some clues which will help in the differential diagnosis of unilateral dyschedema, the most common being non-arthritic AION. We also have arthritic AION as a differential diagnosis. Other causes will include optic neuritis and CRBOs. Rare causes will include compressive optic neuropathy, secondary to a tumor, infiltrative optic neuropathy due to leukemias, neuroretinitis due to cat scratch disease, and ocular hypotony post-trap. So differential diagnosis for a bilateral dyschedema will include papilledema, a hypertensive retinopathy, diabetic papillopathy. Diabetic retinopathy need not be present in such cases, and toxic optic neuropathy. So step 4 is to identify, once you have established a bilateral dyschedema, is to identify papilledema, which is a neuroophthalmic emergency. The symptoms will include headache, TIAs, double vision, pulsatile tinnitus, where the patient hears his own heartbeat, and nausea and vomiting. And signs will include dyschedema and large blind spots, retinal hemorrhages, and impaired lateral gaze secondary to 6 nerve palsy. So intracranial causes of papilledema will include idiopathic intracranial hypertension with normal neuroimaging and just an elevated lumbar puncture pressure, intracranial space occupying lesions, intracranial infections, and also venous sinus thrombosis. So other systemic causes will include medications, obstructive sleep apnea, polycystic ovarian disease, and microcystic anemia. So let's put our knowledge to the test. So the first case is a female with a recent weight gain. She's presenting with a bilateral disc edema. You check the BP, it's normal. Then you send her for neuroimaging and you find out that the CSF opening pressure is high. So the diagnosis is idiopathic intracranial hypertension. Second case is a 38-year-old female who is presenting with a painful eye movement. You are finding a unilateral disc edema. BP is normal. You send for neuroimaging. Everything is okay except for an increased contrast sensitivity. Probable diagnosis is optic neuritis. Yes. So third case is a 64-year male who's a known diabetic, and he's presenting with a fundus picture like this. And you run and check the BP, it's 200 by 100. So it is grade 4 hypertensive retinopathy. So I'd like to conclude with just 3 takeaway points. When you see a case of disc edema, check the pupils, check the color vision, and check the blood pressure. Thank you. This is Team Retinopathy.
Thank you, Dr. Prasanna. What is the management in cases of pseudo disc edema? And what is the commonest cause you have seen?
Sir, basically we associate IIH with certain epidemiological features like females who are obese and who are on oral contraceptive pills. So the management is just to reduce the CSF, elevated CSF. So we go for hyperosmotic agents like mannitol or acetazolamides.
अरे यार मैंने ऊपर नहीं पढ़ा मैंने कहा तुम लोग आए नहीं कोई नहीं बोलो थैंक यू
Yes.
ओके अच्छा नहीं जज कौन है coordinator लिखा हुआ इसको this I got from outside अच्छा अच्छा अभी कौन सा है you may have to repeat
Okay. Sir, can I come back after my or to do it again now?
you want this
Yes, sir. I have a poster from 2 to 3.
Okay, good afternoon, Dr. Krishna Prasad. I'll be the coordinator and the anchor for this Teachers of Tomorrow. This is second round of the preliminaries. So yesterday we had around 22 students presenting, representing their team. It's a team of 2 mentees. Only one person is allowed to present because of the shortage of time. But in the finals, obviously, both will be getting a chance. So this is a situation where this is actually your steps into public speaking. Obviously, you'll be speaking to patients, peers, and public in future. So this is not your subject seminar class. It's not your routine teaching program where you have hundreds of slides and go over it and, okay. Here you are going to teach like a teacher. Consider the whole thing as a class, and you have only 4 minutes, and the marks are totally maximum 10. 4 marks maximum for the content. How is your slide, the slide design, the use of videos, photographs, animations. Okay, so maximum 4, and other 4 is for your speaking skills. You know how good you are in your oratory skills, your histrionics, your voice quality, your confidence. Okay, all those things will carry 4 marks. Again, you can get maximum 4 out of that. So that is 8, and 1 mark is for finishing before time. You have only 4 minutes. Since we have no time here, this is very, very strict. If you're almost, there'll be a thing that will come as time's up. It will come and show. You don't have to say anything. You will know actually the time running here. If you are almost at the conclusion, I have requested the judges to still grant you 1 mark. But if you are nowhere near the conclusion, you continue to speak even after the time's up warning, then you will lose that 1 mark. So that's a low-hanging fruit. Please make sure you conclude looking at this. This is also a skill in public speaking. You should know your timing. You should have rehearsed well. Okay? And 1 mark is for the questions. The judges will ask by rotation. Only one question will be asked. They have no time. So they have already missed their lunch. They will miss their dinner also if you are asking more. And it is by rotation. You decide who is going to ask. And one question that may be either 0 or half or 1 mark. So that's how we compile it, right? And soon after this session, we are going to actually announce the results. Sorry for having it in a small room with less ventilation. But anyway, it's a warm hospitality from AOS. Let's it get warmer as the things go. So we'll probably start with Nilima with the first one. Dr. Mansi, hope you all loaded your presentation. No laptops here, okay? And once you start speaking, they will switch on the timer. Okay? Once you start your first sentence, they will switch on the timer. And be confident, look at the eye, don't look at the judges. Look at the eye, you are addressing to a class, so the class should be afraid of you, not you, right?
Dr. Mansi, fifth, हाँ, इसके ऊपर, the one above it, हाँ, this one. Shall I start?
Yeah.
Okay. Good morning, good afternoon, everyone. So ROP is a vasoproliferative retinal disease of the preterm and low birth weight babies. As we know, we are in an epidemic of ROP in developing country like ours, where an estimated of 18% of all babies born in our country are preterm. This poses more than 3 million babies a year to developing ROP. Considering the grave burden of the disease it has on our population, screening is the most effective modality to tackle it. So when it comes to ROP screening, we have a lot of questions: whom, when, how, what, where. So we are going to answer all of that in the next 4 minutes. So whom to screen? Babies with birth weight less than 2,000 grams, gestation is less than 34 weeks, between 34 to 36 weeks, provided they have some risk factors which we'll discuss, and infants with unstable clinical course who are at a high risk of developing ROP, and these are the set clinical features. When to screen? So there is a famous saying, 30 din roshni ke. So the babies have to be screened within the first 30 din of their life, or within the first 4 weeks of life, and gestational age less than 28 weeks. Birth weight of less than 1200 grams should be screened within the first 2 to 3 weeks of their life. And who can screen these babies? Any trained ophthalmologist can screen. So you don't have to be a retina specialist or a pediatric retina specialist. Any trained ophthalmologist who knows to identify and stage the disease, is skilled with comprehensive indirect ophthalmoscopy, and can interpret retinal images to identify and stage ROP, can screen ROP. And where to screen these babies? Right at the birth in NICU, where they're admitted, or after discharge, stable babies can be screened in their NICU visits or in ROP clinic. And how to screen these babies? So you maintain asepsis, you keep the examination as brief as possible. There you have to put topical proparacaine and dilate both the eyes. This is very important because the commercially available drops are not suited for these babies. You have to use low concentration, which is 2.5% phenylephrine and 0.5% tropicamide, as opposed to the commercially available ones. 0.5% cyclopentolate can also be used, or you can dilute the commercially available drops. Now, what do you want to look for? You want to look at the zone of the disease, the extent, the stage, if the presence of plus disease or aggressive retinopathy or prematurity. So there are 3 zones. And there is a zone 2 posterior, which was recently introduced. So the first 16 weeks of life, the retinal vessels just start to grow from the optic disc, and by the 36 weeks, they reach the nasal ora serrata, and by 40 weeks, they reach the temporal ora serrata. So once you know the normal physiology, you should know what signs are there to catch ROP. So in stage 1, you see a demarcation line. Once this demarcation line gains some weight and height, it becomes a demarcation ridge in stage 2. In stage 3, the demarcation line is accompanied by another friend, which is a fibrovascular proliferation, and it progresses to retinal detachment in stage 4, 4A and B, and then stage 5 is total retinal detachment. You should also know what plus disease is. It is characterized by dilated tortuous vessels at the posterior pole, which should be at least 2 quadrants to call it significant. And aggressive retinopathy of prematurity is another thing you should know of, which occurs in very small babies. The junction is featureless. There is no demarcation line. There's severe plus disease. As you can see, vascular loops are here and flat neovascularization. These babies progress very fast. And as you see, if you see this grave sign, cortunica vasculosa lentis, you can assume that the child is unfortunately bearing aggressive disease. So how do you screen? In step 1, you examine the posterior pole, then you examine the remainder of the retina up to the ora serrata in each quadrant, and scleral indentation is to be done. You document your findings well and then counsel and refer accordingly. So how do you follow up these babies? If the disease is not detected, you follow up and review at least every 2 weeks until either vascularization of retina gets completed, the ROP regresses completely, or the ROP requires treatment, for which you have to urgently refer to a pediatric retina specialist. So one blind child is a tragedy, but 1 million blind children becomes a statistic. Let us not make our children be part of that sad statistic. Thank you all for your attention.
Do you have a small hand mic? Okay, we have a question.
Yes, sir.
The baby
Hello,
is
hello.
born at 28 weeks
Yes, sir.
and it is weighing 1200 grams.
Yes.
Today, let's say.
Yes, sir.
So now what will you tell the pediatrician attending the patient in the NICU about the screening protocol, when he should actually refer the baby to you?
Yes, sir. So according to the national guidelines published in 2017 by the RSB, the Rashtriya Suraksha Bal Karyakram, these babies have to be screened early, as soon as possible, possibly within the first 2 to 3 weeks of life. So even if you are screening the baby early and you detect no disease, the screening has to be repeated every 1 to 2 weeks, and then the progression.
He's ready to send it today itself.
Sir, today, sorry?
He's ready to send the baby right now, today itself.
So if it's a small weight baby, we would prefer to go in the NICU, give them the pediatric formulation of tropicamide, and within first 48 hours, the ophthalmologist has to come and screen.
He's going to bring the baby, everything, don't worry.
Okay.
But you would like to examine the baby immediately?
Within the first 48 hours, sir, according to the guidelines, you should say. Within the first 2 to 3
You
weeks,
mean
it
within
should be
48
exactly.
hours the ROP will develop?
So, sorry, sir?
You want to wait, see the baby
No,
within
no.
48 hours?
No, sir. As per if they're ready to urgently send the baby, we have to see it urgently. But then the baby has to be followed up also, because these babies are at a very high risk of
No,
developing
I'm getting
AROP.
confused. Is ROP there at birth?
ROP will develop after birth. So there are certain risk factors.
So should you see the baby immediately?
So we have to immediately, I'm not sure, but there are risk factors.
Okay,
Sir.
right. Okay, thank you, Dr. Mansi.
Thank you, sir. Thank you.
Dr. Samarpita? Yeah. Don't start, wait. So we have a very transparent system here. The judges will actually show the marks right here to the scorer as well as to the crowd, so that you will know exactly that it's a very transparent system. Each will know their marks. So the judges, you can please show a placard to the scorer. I think all have to clap. Okay, you all have your lunch hopefully. Okay. So Dr. Samarpita?
Yes, sir.
Yeah.
Shall I start?
Yeah.
Shubho Aparan Ho, Kolkata. Did you see that famous movie in which the lead actress was having an expressionless face? She must be using Botox, na?
This is the topic where UPG is low less when compared to actresses. So please focus, as a lethal dose of 0.1 mg can kill a human being.
Correct. As it is derived from Clostridium botulinum, which is a deadly food poisoning called botulism, and was the first biological toxin to be used in ophthalmology and for aesthetic purposes. So, its ultrastructure is very important for you to know the mechanism of action, as it is composed of a light chain and a heavy chain, has 8 serotypes, among which type A is the most potent one. Class, please pay attention. This is a very important topic for you in the exams. So, coming to how does it act? So, the light chain causes cleavage of SNAP25 protein, which is responsible for the exocytosis of acetylcholine. So, there is no degranulation and no release of acetylcholine in the synaptic cleft.
If there is no acetylcholine, there will be muscle flaccidity. So it can be used either in spastic muscle conditions or to decrease the secretions.
Correct. Also, it is available as toxin A, which is a prolonged effect has and is more potent in comparison to toxin B. Also, clinically, it can be used in a variety of subspecialties. So, students read about it and tell me in the next class. So coming to ophthalmology, it can be used in orbicularis myokemia, which is an involuntary single-sided twitching of the upper lid, and also in benign essential blepharospasm, which causes functional blindness.
Functional blindness, as the patient doesn't has organic blindness, but the patient is unable to open the eyes. So it leads to functional blindness.
Correct. Also, in other facial dystonias like hemifacial spasm and Meeks syndrome, it is used. Similarly, in upper lid retraction seen commonly in thyroid eye disease, in which we inject Botox into the LPS to cause an improvement,
More reduced LPS action can lead to ptosis, which is not gradable.
which is a side effect. Also in entropion, when there is an overaction of orbicularis oculi, and also when there is an excessive lacrimation to block lacrimal gland.
Reduced lacrimal gland secretion can lead to dry eye, which is another spectrum.
Which is also a complication. Similarly, in lag of ophthalmos and in neurotrophic keratitis to improve and prevent the corneal exposure and also to induce ptosis. Similarly, in squint, when the child complains of diplopia and surgery is to be delayed. So coming to your favorite slide of the day, how can it be used cosmetically? It is used in lateral dentites.
Array, say crow feet, na?
Correct. Also in forehead wrinkling and glabular frown lines. So how is it made? We take 2 ml of normal saline and inject it into 50 or 100 units of botulinum toxin. Thus, 0.1 ml of this formulation contains 2.5 or 5 units of Botox.
You have made it. Where will you inject it?
These are the sites of injection.
How much and how will you inject it?
Subcutaneously, it is injected 2.5 or 5 units and also subtenon and intramuscularly.
Where is it contraindicated?
Obviously, in disorders involving the nerve muscle junction and the myopathies. Thank you so much.
Array, wait. I want to test how much you have learned from her presentation. Botulinum toxin acts by, yes, inhibition of acetylcholine release. You are all attentive. Mode of botulinum toxin injection is subcutaneous. Array, wow, you have heard it. Thank you.
Very nice, very nice. I should really compliment the mentor for such a unique, innovation. Now we're going to give you 5 marks each. Is it okay?
Yes.
Because you both
How should we
be
divide?
happy, right? That will become 10. No. Now to the judges to ask a question and then marks.
So, do you think that in a squint it works really as it is expected?
No, sir. It is usually used in small angle deviation less than 40 prism diopters and also in cases in which we need to delay the surgery.
I think you should have what you should have done is that the clear-cut indications and indications, which if you divide these in 2 parts, that these are clear-cut indication which we must use, and this is on trial, then I think it would have been a little better.
Yes, sir.
Okay, thank you. Well
Thank you
done.
so much.
I think a round of claps for her. I will tell you the next 3 contestants so that you will be ready mentally. Dr. Asta, you are there? Please take the stage. Dr. Nishi will be coming next. Are you ready? Okay. Dr. Sai Karthik, you are there? Okay. So this is the order of the next 3. Can the judges have the show of marks? Dr. Asta. First. Okay, yes.
Good afternoon all. The topic for today's class is idiopathic intracranial hypertension. These are going to be our learning objectives for today. So what is IIH? It's also known as pseudotumor cerebri, and it's a disorder characterized by increased intracranial pressure of unknown cause that predominantly affects obese women of reproductive age group. There are various pathophysiological mechanisms described, which are cerebral edema or stenosis of the distal portion of transverse venous sinuses, which causes cerebral venous hypertension, leading to impaired CSF absorption, increased intra-abdominal pressure, leading to increased cardiac pressure, which impedes venous return, and increased vitamin A, which hinders CSF resorption. The incidence is 0.9 to 1 per 1 lakh general population, and the risk factors include systemic illnesses and exogenous substances. The systemic illnesses include obesity, obstructive sleep apnea, and chronic respiratory insufficiency most commonly. And exogenous substances include tetracyclines and vitamin A intake. The patient presents with headache most commonly, which is worse in the morning and can worsen in change in position, coughing or sneezing, and can occur daily and may vary in location. The other features are nausea and vomiting, back and neck pain, and dizziness. The patient can also present with pulsatile tinnitus, which occurs due to turbulent blood flow in the arteries. The other vision related problems are blurring of vision, flashes, and double vision. The only sign which can be seen in cases of IIH is papilledema, which is characterized by elevation of optic disc and blurring of the disc margins. So because IIH is a diagnosis of exclusion, we have a diagnostic criteria which was given by Dandy, and it has 5 points, which is increased ICP, no localizing neurologic signs, and raised CSF opening pressure, no structural abnormalities, and no other cause of increased ICP. There are various MRI features, which includes raised intraocular portion of the optic nerve and tortuosity, stenosis of the transverse sinuses, and empty sella sign. The management includes lifestyle modifications, which is mainly weight loss, and medications include acetazolamide, which reduces ICP by decreasing the production of CSF. If acetazolamide is intolerated, it can be substituted by topiramate or furosemide. The surgical management includes lumbar puncture, optic nerve sheath fenestration, and shunting. Lumbar puncture, it's a diagnostic as well as a therapeutic procedure. In optic nerve sheath fenestration, a window is created in the optic nerve sheath, which leads to the egress of the CSF, thereby relieving the pressure, and shunting, in which lumboperitoneal shunting or ventriculoperitoneal shunting can be done. So coming to summary, IIH is a neurological disorder which is characterized by raised ICP of no apparent cause. The risk factors include obesity, obstructive sleep apnea, vitamin A and tetracycline intake. The patient presents with headache. The main feature is papilledema. The diagnostic criteria is modified Dandy criteria. The management includes weight loss, acetazolamide, and surgical options.
Oh, well done.
A very thin lady of age of 30 years. All investigations are normal, fundus is normal, MRI is normal. What is your plan of management in such cases? With sectional palsy.
So
She develops sectional palsy, but there is no signs of IIH. Neurologist sent for fundus examination by suspecting IIH.
So fundus is normal for the patient.
All investigations are normal.
Only isolated sixth nerve palsy is there. So I would like to go ahead with the neuroimaging first and see.
That is normal. Otherwise, very difficult case for us. But we have to give all blindly all treatment. No.
Okay, I'll simplify his question. Other than papilledema, how can an ophthalmologist suspect IIH?
So it's a bilateral sixth nerve palsy or unilateral sixth nerve palsy is
Why does it happen?
So it's a false localizing sign.
I know it's, but how does it happen? What is the pathophysiology of a sixth nerve palsy in an IIH?
So because the sixth nerve passes above the petrous bone apex, and because of the cerebral edema that presses upon the sixth nerve.
Cerebral edema in IIH?
Sorry, the increased ICP, the dilated ventricles, they will press upon that and will cause sixth nerve palsy, which is a false localizing sign.
No, it is the pressure which actually pushes the entire cerebral hemispheres down. So since the sixth nerve is hooking over the petrous temple, it gets pulled. There's a neuropraxia that happens. Okay. Right then. Thank you very much.
Longest route, no?
Yeah.
It has longest route.
Okay. You can have a round of applause for her. Well done, Dr. Asta. So I'll tell you the whole sequence now. Dr. Nishi is here. So you are next. Be there. And Dr. Sai Karthik is coming next. And who is presenting from King George Medical University? Priyanka Tapan. Priyanka, okay. Then Sai Tejasvi. Is Sai Tejasvi here? Or his... Okay. Debalina Chatter, okay. Bhattacharya, okay. And Narendra? Narendra is here, okay. Aishwarya Ramog, who is presenting? Aishwarya Ramog.
So a very good afternoon to everyone present here. I am Dr. Nishi. I am from Team Sabdajang. I'll be presenting Exophthalmometry in 4 minutes or less. So we'll have a brief introduction. We'll inspect and suspect a patient. We'll palpate to evaluate. And what next? We'll investigate. Exophthalmometry is a relational measurement between the corneal apex from the lateral orbital rim. It can be measured clinically, radiologically, or using digital photography, especially in this age. So I see a patient in my OPD. I suspect that there's asymmetry between the eyes. What can I do? I can change my perspective. I look at the patient from above. I look at the patient from below, using the superior orbital rim as my index. Okay, there is asymmetry. I take out a very simple object from my pocket, the Lewitt's exophthalmometer. I place the notch against the lateral orbital margin. I see where the corneal apex is lying. This gives me a unilateral reading. Is there something even more simple I can do in the OPD? Yes, I can just use a plastic ruler and see where the corneal apex is lying. Okay, this gives me a somewhat unreliable reading. We all know about the Hertel's exophthalmometer. It's a horizontally calibrated bar which has 2 sliding carriers. The carriers have inclined mirrors at 45 degrees to each other, and we get a mirror image of the corneal apex. The base can be used for future references, decreasing our variations. Okay, so at the same level as the patient, we ask the patient to look straight. We try to minimize the parallax by joining these 2 lines. We see where the mirror image of the corneal apex is lying. Okay, what can I do wrong? I have to be very cautious. First, I have to close the ipsilateral eye. I have to make sure the eye is looking straight. I have to make sure that the lids are not getting deformed due to my actions. And the patient should fixate on a target. I want to eliminate this parallax. I am done with it. Okay, how about we use 1 reflective mirror instead of 2? This is exactly what the Moritz exophthalmometer does. My patient has come to me in my OPC clinic after a lateral orbitotomy or with a huge trauma to his lateral side. I can use the Noggles exophthalmometer. I won't have to use the lateral orbital margin. I'll use the superior and inferior orbital margins. I can also see one more thing. I can see where the vertical level of the eyes are. Okay, so this is the summary of the common exophthalmometers I've talked about. We're talking in millimeters here. So every race has a different cutoff. We can't use cutoff as the target point. An asymmetry of more than 2 millimeters is what we should focus on. Millimeters again, okay. How can I objectively see where my proptosis lies? The Hilal and Trokel method uses a CT scan where we join a horizontal line from the lateral orbital rims. We draw a perpendicular line to the corneal apex. This is our absolute value of proptosis. Can we also use a sagittal section? Yes, we can use the superior and inferior orbital markings. What if the patient gets only an MRI done? Okay, we use the interzygomatic line in this case. If MRI is being used as a established tool, there are so many more things we can do. We can grade the proptosis. We can also use an exophthalmos index. Okay. Radiological investigations are extremely important because we also get to know the cause of this proptosis or an ophthalmos. It looks like we had an eye-popping session of screening, subjective and objective methodology. What kind of a teacher would I be if I did not thank my own professors, Sangeeta ma'am, Anuj sir, and of course the patients who are the first teachers who have made all of this possible. Thank you so much. Any questions, I'd be happy to take them.
So you would like to use this exophthalmometry for all the diseases as uniform way of evaluating, or anything you want to differentiate between the different disorders, like thyroid exophthalmometry and
So exophthalmometry, of course, will have to be performed. We need something which is repeatable in all and easy to do in all our OPD clinics. So Hertel's exophthalmometer is actually routinely used in our clinics still. Of course, if the patient did get a decompression surgery, I would need to do a Noggles exophthalmometry in that case because I don't have a proper rim for examination. If, for example, my patient does not want to be palpated, then I can do a digital photography. It's an upcoming method where I can just take pictures of the profile view of the patient and see where the corneal apex lies with respect to the lateral orbital margin. So that is one more thing I can do. Yes, sir. Not in our setups.
Can judges give the marks to me? Thank you so much. So the next participant is Dr. Y. Sai Karthik. He is on number 4 of the list. Number 4, Hyderabad Rangers.
Yes. So, a 32-year-old male patient had a history of trauma to the right eye 1 year back, and his fundus anterior segment examination was within normal limits. Fundus examination showed some optic disc changes. So, on gonioscopy, we found that there was angle decision, so has diagnosed as an angle decision glaucoma. So, class, I am Dr. Sai Karthik. I will throw some light on gonioscopy. So, gonioscopy is a clinical technique used to examine the structures of the anterior chamber. Way back in 1907, Alexander Trantas was the first scientist who visualized the angle with the help of limbal indentation. With the indirect ophthalmoscope, he indented the limbus and saw in the keratoglobus patients. So in the picture C, you can see normally when the light transverses and hits the cornea in the more than critical angle, all of the right rays are reflected. So that's why we won't be able to visualize see the angle through a naked eye. So this phenomenon was eliminated later by Salzman, where he kept a direct gonial lens on high power convex lens on the cornea, thereby changing the cornea air interface to cornea lens interface. So by this principle, direct gonioscopy works, where we can visualize the angle directly. And indirect gonioscope, a mirror is mounted and provides a reflected image. These are few direct gonial lenses. They are Koppe, Swan-Jacobs and Hodgkins-Birken. Indirect gonioscopes are Goldman 3 mirror, Sussman and Posner. So few indications of direct gonioscopy are they are used in therapeutic purposes, mainly to diagnose congenital glaucomas and in minimally invasive glaucoma surgeries. And indirect gonioscopy is used in regular basis for the clinical examination in OPD setups to visualize the 4 quadrants of the angle. So it is done in the ambient light condition, where a 2 to 3 mm of parallel slit is applied, and care to be taken not to fall the light on the pupil, because it will cause meiosis and false opening of the angles. So here in the plane, the small part of the anterior part of the plane is called cockpit. Though it's very small, it functions the whole plane. That's why that is the importance of the angle. Angle is also called cockpit because it's a small part but functions the whole anterior chamber. As in this picture you can see, this is the iris and this is the ciliary body band. Above the ciliary body band, white structure you can see. This white structure is the scleral spur, and above the scleral spur there is a pigmented trabecular meshwork, and above the pigmented trabecular meshwork is non-pigmented anterior trabecular meshwork, and above it is a solvase line. So this, hence we have visualized the normal angle. Let's see about some quiz time. So this is a 78-year-old male patient complains of diminution of vision in both eyes. In the pupillary margin you can see the dandruff-like material accumulating. What is this? So it starts to show pseudoexfoliation. The seen is some policy line. It is also seen in pigment dispersion syndrome. This is a 52-year-old male, uncontrolled diabetes. On fundus you can see proliferative diabetic retinopathy. What is that is seen in the gonioscopy? That is a neovascularization of the angle. This is a 78-year-old female who had old history of uveitis in the past. So you can see lumpy bumpy appearance of the angle. What is it? It's a peripheral anterior synovial closure. And this is a 28-year-old female diagnosed to have carotid cavernous fistula with elevated epicellary venous pressure. What can you see in the angle? This is a blood in the Slem's canal. So around 50% of the glaucomas in the South Asian countries are due to primary angle closure glaucomas. But these all glaucomas are going unnoticed because of the lack of gonioscopy that we are doing in our country. So it is a dire need that every ophthalmologist should practice doing gonioscopy and master the art of gonioscopy. Gonioscopy is not a mere technique, it's an art. Thank you.
Thank you so much. Judges, questions?
What is a dynamic gonioscopy?
Sir, dynamic gonioscopy, indentation gonioscopy, sir, where we indent, normally occludable angles will be there. On indenting the gonial lens, we'll open the angles, we'll be able to see the posterior trabecular measure, sir. That is also called dynamic gonioscopy. Thank you, sir.
Can judges show the marks to me? Thank you so much. So the next participant is Dr. Priyanka from the team King George's Medical University. She's number 5 on the list.
Good afternoon, one and all. So today we will be discussing about phakic IOLs. What are the phakic IOLs? Firstly, we would want to familiarize with the concept of phakic IOLs, the optics behind it, the indications and contraindications, types, surgical options available, and complications. So why phakic IOLs? So we use phakic IOLs where there are high ametropia which cannot be handled with the refractive surgeries available. It preserves the corneal architecture and gives us a predictable result. The concept of phakic IOL was introduced early in the 1953, and now we have sophisticated implantable phakic contact lenses. The optics behind the phakic IOLs is we have the intraocular lens, and these IOLs are implanted in front of the existing crystalline lens. The indications of phakic IOLs is high myopia, high hyperopia, high astigmatism. The most important part about implanting a phakic IOL is patient selection. Firstly, age more than 21 years, stable refraction, clear crystalline lens, anterior chamber depth of more than 2.8 mm, minimum endothelial density of 2000, and no ocular pathology. Also, it is important to note the white-to-white measurement for proper sizing of the intraocular lens. The types available are anterior chamber, which are angle supported and iris fixated, and posterior chamber IOLs. In posterior chamber IOLs, we have implantable columnar lenses and implantable phakic contact lenses. The important part to note here is these lenses have central and paracentral holes which facilitate the movement of aqueous, and it eliminates the need of PI. The advantages being it is reversible, gives us predictable results, also importantly preserves the corneal architecture and accommodation. The disadvantage being stringent patient selection criteria. Also, the major advantage being flat learning curve. Here, this is a borrowed video from the internet where I would want to highlight a few steps of phakic IOL implantation. An incision of 2.8 mm made. The IOL is folded and inserted into the anterior chamber. The haptics are then put behind the iris. And then the haptics are pushed behind the iris. The complications encountered are increase in IOP, endothelial cell loss, cataract, and pigment dispersion, the occurrence of which is mostly related to the type and placement of intraocular lens. The take-home message after the short session is from my end that technological advances have given us a bright ray of hope to the refractively challenged. However, the surgeons need to exert a caution in case of case selection and surgical performance. Thank you.
What are the parameters you take in consideration before deciding that patient is fit for surgery or not, and which IOL you are putting? All companies have different criteria.
So firstly, important is to assess the cornea. Then we assess the anterior chamber depth, and the sizing depends upon the white-to-white measurement of the iris.
How it is done?
So white-to-white measurement is, we have digital calipers or our age-old mechanical caliper. Although patients get a little apprehensive when we push the digital caliper, it is so big. So another way to put that is put the mechanical caliper and then make the impression of it on a paper and then measure it with a digital catheter. This way we confirm the findings. Also, this can be done on corneal topography machine or biometry.
What is the final cutoff for AC depth? You know,
So 2.8 mm minimum.
In the indication you mentioned, high hyperopic can be used for the phakic IOL.
Yes.
But usually high hyperopics have a very shallow AC.
Yes, sir.
And contrary, it is a contraindication for the phakic IOL.
So, but
because the phakic IOL ultimately reduces the depth of entry chamber.
Yes, sir.
There is a high chance that you will get a secondary glaucoma and angle closure.
Yes, sir.
So high hyperopia, you need to be very cautious about phakic IOL.
Yes, sir.
Instead, go for the clear lens.
Clear
extraction.
lens extraction.
And as far as your content of the presentation is concerned, I would say you have covered everything theoretically. You need to stress on the practical points, that is surgical points. What are the things to be considered while doing the surgery? Though the learning curve is very less, but there are very key points doing the phakic IOLs. What happens if you get a flipped IOL? What
Yes.
you will do?
Yes, sir.
In case of flip, if it opens upside down,
Yes.
what you will do?
So try to extract back or flip it back in the chamber itself, avoiding the corner. So I'll have to. Yeah.
That means you don't know that.
So I
you
was
have to
most
explant.
explant, or so I was mostly focused on the concept of
See,
phakic.
phakic IOL is a very practical topic. Every ophthalmologist must be doing it because there is hardly any learning curve to it. But there are salient features you need to look after. There are very important points that should be stressed in this. I was expecting you to stress on those points. Anyway, well done.
It is very important that you are
You
doing
need to remove that IOL.
you're doing a surgery in a normal eye just for cosmetic purpose. So you should be very cautious. The patient should not be harmed. Otherwise, you can make the patient blind even. And what is the cutoff for vault next day? How much vault is required?
Yes, sir.
Should be there.
Yes.
How much?
So 0.2 to 0.3 mm we need.
Micron.
Micro.
You should have also mentioned oversized eyes, phakic IOL, undersized phakic IOL. How it is judged? Which
Yeah.
are the things one need to look for?
Yes. So
Vaulting of the IOL.
vaulting of the IOL.
You have not mentioned on the vaulting.
Yes, sir.
Okay. Thank you, judges. Can we have the scores? 6, 7, 8. Thank you so much. So the next participant is Dr. Sai Tejasvi. She's here. She has gone for her poster presentation. So we'll take the next candidate. She is Dr. Devlina Bhattacharjee from Vision Vectors.
6.
Yes, she's on number 6. She's on number 7. Number 7 on the list. Vision Vectors. Yeah, start.
Good morning, class. So the topic for today's presentation is community screening of diabetic retinopathy. As I can see, you have traveled from all over the country to come to the land of sweets. But if it goes unchecked, this is how your retina might look like in a few years from now. So let's go on to the screening procedure. What is screening? It is the presumptive identification of unrecognized diseases in an apparently healthy population by means of tests or examinations that can be done rapidly and effectively. So diabetic retinopathy is a prevalent condition in a country like India, where 16.9% of the population have diabetic retinopathy, of which 3.6 might even be facing vision loss for it. The alarming concern here is the ophthalmologist to population ratio, which is approximately 15 ophthalmologists per million population. So diabetic retinopathy, if it is identified early, the complications might get prevented. So the need for screening is absolute. Who should be screening? They are clinicians, trained ophthalmologists, trained optometrists, or clinicians in their own practices, and trained civic volunteers who can be trained to do that. How do you screen for diabetic retinopathy in a community? It might be opportunistic screening where the patient comes to you in your clinic. It might be the use of fundus cameras and mobile vans that can go to geographical locations which are inaccessible otherwise. Systematic screening includes the use of regular camps to detect diabetic retinopathy, the recent use of fundus images with smartphones, and the new advance here, that is artificial intelligence. Now the question arises how to effectively screen for diabetic retinopathy in a large population. The previous OCT machines and fundus photo image taking machines, they are quite cumbersome. Hence the need for portable machines that can be taken in a bag, fundus cameras, smartphones that can be used also. Now, teleophthalmology is a branch of telemedicine that delivers proper eye care through digital medical equipments, and West Bengal has been successful in implementing this. It goes by the name of Swasthya Ingeet. The images are captured at distant sites. They are transmitted to the reading centers where it is graded, and referrals can be made in the same setting as well. Now, the recent advance in this field is artificial intelligence, which eliminates the need for human grading, and it can provide accurate images by the use of anatomical detections. The optic disc is located, the capillaries are located, and appropriate grading is done henceforth. This is, as you can see, the image of a heat map generated on AI according to the severity grading. However, there are few challenges as well. That is lack of awareness in the community, the misconceptions regarding the causes, poor socioeconomic status of the population. There are a few remedies for it as well. That is community-based outreach screening, strengthening diabetic retinopathy services at the health system level, and patient education. So the take-home message here is that you need to encourage the public for enrollment in screening. You need to do public awareness by means of TV or newspapers, etc. To improve screening, we need to eliminate the language barrier that arises in various locations, introduce latest technologies for the screening purposes, and a good transport mechanism as well. So thank you all for your patient hearing. It was lovely teaching you.
Very nice presentation. Now, we should cooperate with us some physicians or diabetologists. Will it be easier?
Yes, sir. Absolutely, because the patient initially they do not know about whether they have diabetic retinopathy or not. They might be thinking it's just simple vision diminution. So if the patient presents first to a diabetologist, they should be referring the patients to ophthalmologists, or we can even ask them to get them screened, and the grading can be done by ophthalmologists.
So I think our community services should be re-looked into for
yes,
implementation.
Sir, absolutely. The burden for diabetes is rising in India.
I think education it is very important to give education.
Yes, sir.
More stress should be on the education, that because those who have diabetic retinopathy, for that you have to treat them.
Yes, sir.
But those who don't have the diabetic retinopathy, suppose, but they are diabetic, then you have to stress on education, which is very important, because 90% of patients don't know what to eat, what not to eat. I have seen patients, they are not taking medicine, they are taking medicine, they are eating sweets also. So this is more challenge in the market, in the public area. So I think, and I ask many patients, why are you doing like this? Doctor साहब हमारे साथ तो कोई डॉक्टर बताता ही नहीं कुछ, but physician is not talking. You have to devote some time with the patient. Instead of treating, you have to educate the patient. If you talk 2 words, he will learn 4 words. So education is very important. Screening is one part, and education should be another part at the same site.
Thank you so much. Can we have the marks? 9, 8, 9, 8.
Thank you, sir.
Due to paucity of time, we'll be taking only 2 questions from the judges. So the next participant is number 8, Dr. Shepsan Mohammed from Towards Tomorrow. He is number 8 on the list. Monocular diplopia, Shepsan Mohammed.
Good afternoon. How's the energy levels, everybody? I can't hear you. Good. So myself, Dr. Shepsan Mohammed, and today I'll be presenting a case on the evaluation of a case of monocular diplopia. So, what is diplopia? In Greek, diplos means double and ops means eye. when more than one image of the object of regard is seen simultaneously, or simply when an individual sees two images of a single object instead of one. Let me explain.
It's okay, we can pause and then start again if you have not able to. Carry on.
Ma'am, can I restart?
No, carry on, no problem.
Okay. So, according to the theory of neurophysiology of vision by Hubel and Wiesel, when the light from an object falls on the corresponding points of both the retinae, the image of both the objects fuse to form a single mental impression. This is called as sensory fusion. This sensory fusion is maintained by the vergence movements of the eyes, and that is called as motor fusion. This sensory fusion and motor fusion is very much important for maintaining your binocular single vision. Sir, then what is monocular diplopia? Very good question. In that case, we have three mechanisms: light diffraction, metamorphopsia, and cerebral polyopia. Let me explain. So here, I have a beautiful fundus photograph. Suppose normally the path of light falls, it's straight and falls directly into the fovea. Suppose there is some sort of middle opacity. The light strikes the ball and basically a part of the light falls on the fovea and in the extrafoveal point. So one object, two image, one retina, monocular diplopia. So this can be negated with the help of a pinhole. Now, what is the most common cause of this light diffraction? Mostly a high refractive error, followed by eyelid abnormalities, tear film abnormalities, corneal opacities, lens involvement, and a few other factors. Now, what if the vision is not increasing with your pinhole? Yes, that is when your macula is being involved, mainly a macular edema or an epiretinal membrane. Here, there will be something known as distortion of your images. This distortion of images, it is called as metamorphopsia. The last being cerebral polyopia, which is the only condition in which you will be having monocular diplopia bilaterally. Sir, how do we approach such a case? Yes, you have to ask the history, mainly all the symptoms associated with diplopia. Also, when you examine, you will have to give more focus on the anterior segment like Munson sign, peripheral iridotomy, or lenticonus. How will you approach a case of diplopia? Ask the patient to close one of his eyes. If the diplopia is absent, then that is a binocular diplopia. It is a neurological pathology. Now, if one of the eyes is closed and if the diplopia persists, then that is a case of monocular diplopia. It is an ocular pathology. What will you do in this condition, students? You will have to do an examination with a pinhole, which is a hallmark. And still if the vision doesn't improve, then that is a case of maculopathy. And if there is an improvement in your diplopia, then you have to go for slit lamp examination and ophthalmological examination. So, if you are able to see opacities in your red reflex, then that is because of a corneal opacity or a lenticular opacity. If you are able to see an oil droplet red reflex, then that is because of keratoconus or lenticonus. If you are able to see an asymmetric red reflex, then that is because of anisometropia. Sir, how do we manage such a case? Both ho gaya. So, you will have to go according to the treating the cause. Dry eye, artificial tears. Anisometropia, spectacles. Corneal astigmatism, RGP lenses. Dislocated IOL, go for explantation or implantation. ERM, go for a PPB. And cataract, I don't have to say any much further. Go for SICS or a Phakic. Hope you enjoyed the class. Thank you.
In spite of the disturbances in the presentation or the laptop issues, you finished in time. So that is very good. I think I have no questions to ask you. You have answered every question.
You seen any patient with two people?
Polychoria, sir. Yes, I have seen in my OPD, sir.
No, you seen?
Yes, I have personally seen them.
I have never seen my practice.
Yes, sir.
You want to become a teacher?
Yes, sir. Teaching is actually my passion. That's what I want to be when a good clinician and a good teacher. That's what I want to be in the future.
Nice. 10. Thank you. That's a...
Thank you, sir. Thank you so much.
That was a great presentation. Congratulations. So the next team is, if the presentation is anybody present from the team pictures, Aishwarya or Amog? Anybody from the team pictures, Dr. Aishwarya or Amog? Okay, we're moving on to the next one then. So we have the next presentation by the team Rhinos. It's on the next page, Dr. Anjani Agarwala. Here. Second page. Next. Here.
Tell me the topic. Name of the
Traumatic hyphema.
Traumatic hyphema. She's speaking on traumatic. Okay, so before we start for the presentation, I'll tell the next in line. It's spectaculars. Anybody? Saukanti. Okay. Then we have anybody from the team AHRR. Dr. Devi Karthya. Reshika. Rishika? Niveda. Okay, fine. Carry on. Start.
Good afternoon, students. Today we will learn a very interesting topic, that is traumatic hyphema. So we will learn 4 things here. First of all, what is traumatic hyphema, how to grade it, how to treat it, and when should we do surgical interventions. So first of all, what is hyphema? So hyphema is accumulation of blood within the anterior chamber. Now, from where the blood has come, so as we know that iris blood vessels and ciliary blood vessels are there, so any leakage of blood from the blood vessels will lead to hyphema. Now what is the etiopathogenesis? How that blood has leaked from the vessels. So whenever there is a blunt injury, there will be anteroposterior compression of the globe and simultaneous equatorial globe expansion. That will cause increase in the IOP, and that will stress on the anterior chamber angle structures. That will lead to a shearing force over the iris blood vessels or ciliary body blood vessels, and that will lead to rupture of the iris stromal or ciliary body blood vessels, leading to hyphema. Other than that, whenever there is a penetrating or a lacerating injury, that can directly injure the blood vessels, leading to rupture and hyphema. So, how to grade it? So, grade 0, that is microhyphema, where we have to see the anterior segment in the slit lamp, and we can see the circulating RBCs in the anterior chamber by the slit lamp only. Other than that, stop.
Anyone from the AV team, audiovisual team, please hail me.
Try doing it now. You stopped at. We'll start again. Maybe you can present again. Timer वापस लगा दो.
Good afternoon, students. Today we will learn a very interesting topic, that is traumatic hyphema. So here we will learn 4 things. One is what is traumatic hyphema, how to grade it, how to treat it, and when should we do surgical intervention. So first of all, what is hyphema? Hyphema is accumulation of blood within the anterior chamber. Now from where the blood has come. So we know iris blood vessels and ciliary blood vessels are present in the anterior chamber, and so any leakage of blood from that will lead to hyphema. So how leakage has occurred? So due to a blunt injury, there will be an anteroposterior compression of the globe and simultaneous equatorial expansion. That will lead to increased IOP, and that will stress on the anterior chamber angle structures. And that will cause a shearing force on the iris or ciliary body blood vessels, and that will lead to leakage of the blood from the vessels, and that will lead to hyphema. Other than that, if there is a penetrating or a lacerating injury, that will cause direct injury to the vessels, and that will cause leakage and hyphema in the anterior chamber. So next, how to grade it? So first of all, when there is a microhyphema that we have to see in the slit lamp, there will be blood cells, that is the RBC, circulating in the anterior chamber. Other than that, again stop.
Again? At the same slide.
I think problem with your slides.
Click again.
They stopped here only last time.
Last time, yeah, it stopped there only. Click further.
I'm clicking.
No, your slide came up last time also. Just click once or twice. We'll give you extra time again.
Okay.
Yes, continue.
So other than that, we have to grade the hyphema depending upon the height of the
Yeah.
This one.
If you can just continue orally, we can listen to it. It's okay. Don't worry, you can just start.
Can
Even
I
if-
say it like
yeah,
without
yeah.
PPT?
You can start talking.
Okay, so we can grade it like depending upon whether the hyphema height is less than 33%, it can be grade 1. If it is more than 33%, that is 33 to 50%, it can be grade 2. If it is more than 50%, it is grade 3. And if it is 100%, it can be grade 4. No, you just...
It's okay. Carry on. It's fine, you continue talking, don't worry.
Okay, so depending upon that, we can grade the hyphema. Now, that hyphema that is present in the anterior chamber can cause pupillary constriction or can cause pupillary dilatation because it will irritate the iris muscles. And other than that, there can be associated sphincter tear due to the blunt trauma. The patient will present with pain, diminution of vision, and photophobia. Now, what that hyphema will do or what complication it can cause? If it obstructs the tabicular meshwork, then it will cause decrease in the outflow and it will increase the IOP. If it goes posterior or it into the angle, it will cause peripheral anterior synechia or posterior synechia, or it can cause corneal blood staining. So these are the things which it can cause. So we have to prevent it. For that, we have to initially, okay. So for that, we have to initially take the patient's history. So in history part, we have to ask for ocular history, then systemic history, and then we have to ask for medication history. So ocular history, whether there was any pre-existing glaucoma, whether there was any pre-existing similar illness was there or similar bleeding was present or not. And other than that, in systemic history, we have to ask for sickle cell disease or any blood coagulopathy or hypertension or diabetes mellitus. And other than that, we have to ask the medication history, where we have to ask for blood thinners. Patient is on blood thinners or not. Then we have to identify the other diseases, like if there is any corneal laceration or there is eyelid laceration or corneoscleral rupture, that we have to treat first, and then we have to treat the hyphema. Nextly, we have to initiate the medical management. In the medical management, the first thing which we have to know is we have to ask the patient to keep the head elevated at 30-degree position, so that there is drainage of hyphema, and that will cause decrease of the hyphema. If patient is lying down position or in supine or prone position, it will cause corneal staining or blood will spread over the lens, and there will be no drainage of the hyphema. Next, we have to initiate the medical management, in which we have to ask the patient to start with topical steroids. We have to ask for topical cycloplegics, and then we have to go for IOP lowering drugs. And better to keep an eye shield and keep the patient at bed rest. So normally in a grade 1 or grade 2 hyphema, it will resolve within a week. But if it is more than that, like in case of grade 3 or more, there are 4 to 5 conditions in which we have to intervene surgically. It's like if IOP is more than 50 or more than 60, IOP is uncontrolled, like more than 50 for 5 days, more than 35 for, more than 60 for 2 days, more than 50, more than 60 for 3 days, more than 50 for 2 days, and more than 35 for 5 days. Along with that, if there is any corneal endothelial staining, and other than that, if there is sickle cell disease, or if there is pre-existing glaucoma, in these conditions we have to intervene immediately. So in the intervention, we have to go with AC VAS, that is paracentesis. Normally we can use a irrigation and aspiration cannula, where we can directly irrigate it, or else we have to use if the blood has, like if the clot is present and it has adhered to the iris surface, we can use a Sinski hook to release the adhesion, or we can use a vitractor at low cutting and aspiration pressure to take it out. There is a risk of rebleeding, so we can put the air bubble inside it and close it. Thank you.
Hello. You have covered almost all points, but
unfortunately your PPT was not showing on the display. Huh? So you are losing on that front. And as far as
PPT? Because sir,
question is concerned,
playing there.
how a hyphema can cause a posterior or peripheral anterior synechia. Will you explain the pathophysiology behind formation of the synechia?
If it goes into the like periphery, there will be adhesions between the root of the iris and the trabecular meshwork, and then it will cause peripheral anterior synechia. And if it is got posteriorly, there will be adherence of the iris posterior surface with the lens capsule. There can be formation of the osseous ring also, and there will be like seclusion pupilli, iris bombay will be there, and later on angle closure can cause, later on angle closure can be there. That may also cause peripheral anterior synechia.
Okay.
Can we have the judges' marks? Can we have them?
Just for participation.
Thank you so much for the marks. So the next participant is Dr. Saukanti from the team Spectaculars. She is number 11 on the list. She is presenting herpetic necrotizing keratitis.
A very good afternoon, everybody. Today I'm going to teach you about herpetic necrotizing keratitis. So basically, this herpes simplex virus is of two types, type 1 and type 2. Type 1 causes infections above the waist and type 2 below the waist. This is the picture of the virus. It has a double-stranded DNA. Now, primary versus secondary herpetic infections. Primary usually occurs in childhood as a common cold, and secondary infections is what we ophthalmologists need to know, because secondary infections is what we usually conquer. So, why does this virus cause secondary infections? As you all know, the nerve supply of the cornea is by the trigeminal nerve. So, this virus resides in the trigeminal ganglion, and it causes multiple recurrences. It goes to the cornea and causes multiple reactivations. So this virus presents in all the aspects of the cornea, in the epithelium as dendritic ulcer, geographic ulcer, in the stroma as a necrotizing as well as a non-necrotizing keratitis, in the endothelium as a disciform keratitis. Now we are going to see only about this necrotizing keratitis. It is an infective component of stromal keratitis. Usually stromal keratitis is an immune component. It is due to viral antigens when the body reacts to the antigens. But when you see a necrotizing keratitis, it is of the infective type. So this virus causes direct invasion of the stroma, and what features we can see is that necrosis, epithelial defect and ulceration, dense infiltration of the stroma. It lies indolent for a long time, and there is dense vascularization of the stroma as well. Usually the diagnosis is clinical, but for your exam purposes, you have to know the fact that you can see Cowdery type A intranuclear inclusion bodies when you stain the organism. You can do ELISA as well. PCR is important as it has almost 100% succession rate, and viral culture is gold standard, but remember that we can't do this regularly in the OPD for all the patients. Differential diagnosis includes other form of suppurative keratitis like fungal and bacterial. But how can you differentiate this? The main point you can remember is that viral keratitis has multiple recurrences. So when the patient says he's had previous episodes of recurrences, redness, and you should suspect always a viral keratitis first. And as you all know, fungal keratitis presents with satellite lesions and hypopion and the Wesley ring. So many things you can do to differentiate this and viral keratitis. Treatment, the only indication for stromal keratitis where you give antivirals is a necrotizing keratitis. Whereas like I told you, the rest of the stromal keratitis is due to immune reactions and you have to give steroids. And what we usually give is 400 to 800 mg of oral acyclovir 5 times a day for 10 days, cycloplegia to improve comfort. And topical steroids can be given, but only after the epithelial defect heals. And obviously, you have to do regular slit lamp examinations to know how the patient is responding to steroids. And for that, if there are any recurrences, you cannot give steroids. Surgical options are usually not warranted in viral keratitis because of the recurrences. And residual stromal scarring will warrant you to do a DALC. And usually only 1 year after non-recurrence, you can go for a DALC because of continuous recurrences. Complications include decimetocele and corneal perforations. And take-home message from this class is that early and proper diagnosis is essential for viral stromal necrotizing keratitis, and prompt antiviral therapy should be started early because other treatment modalities like steroids can aggravate the case. Thank you. I've prepared for some handouts for you. For your people, I would like to give these handouts for you to, we can discuss about the herpes, other forms of herpetic keratitis in the next class. Thank you.
Okay, that
But
was
you cannot skip the question. Your question is how if your necrotizing keratitis doesn't heal in 10 days, how long you will give the acyclovir?
Sir, acyclovir should be given maximum for 2 weeks, sir, because acyclovir itself can cause a pseudodendrite formation and cause toxicity for the cornea. So acyclovir we don't give for more than 2 weeks maximum.
400 or 800?
Sorry, sir?
400 or 800? You mentioned
800 mg, sir. 5 times a day.
Can we have the marks then?
Thank you.
Thank you so much. So the next presenter is from the team AHRR. She's number 12 on the list. She's, can you tell me your name, please? Dr. Manisha. She'll be speaking on Phacomorphic glaucoma.
Good afternoon, everyone. Today I am discussing Good afternoon, everyone. Today I am discussing Phacomorphic glaucoma. Before we discuss Phacomorphic glaucoma, we will quickly revise the aqueous humor dynamics. As we all know, aqueous humor is produced by the ciliary processes, and the aqueous reach in the posterior segment. Through posterior segment, it reaches to anterior segment via the pupil. And from anterior segment, aqueous is drained by 2 pathways. Majority is by conventional trabecular pathway, and accessory pathway is the uveoscleral pathway. In trabecular pathway, the aqueous reaches the trabecular meshwork, then Schlemm canal, and with the help of collector channels, it reaches to the episcleral veins and systemic circulation. Now, the pathogenesis of glaucoma. Please remember, in open angle glaucoma, there is no anatomical obstruction to the outflow till the time aqueous reaches the trabecular meshwork. Here the angle is open, so it is open angle glaucoma. Whereas in angle closure glaucoma, we have anatomical obstruction leading to the pupillary block. And because of this pupillary block, the aqueous is not draining from posterior segment to anterior segment, leading to the buildup of the aqueous behind the iris. This can be very easily understood from this sailing boat example. Here we can see the fast flowing wind which is creating pressure on the cloth of the sailing boat, leading to the increased curvature of the cloth similar to the iris bombing. And because of this iris bombing, there is iridotrabecular apposition leading to the angle closure glaucoma and shallow AC. Now, coming back to Phacomorphic glaucoma. As its name is suggesting, Phaco means lens and morphic means morphology of the lens. So as the lens is increasing in size or shape, leading to the pupillary block, leading to the iris bombing, leading to the iridotrabecular apposition and angle closure glaucoma. A quick revision of this mechanism again. A change in the size and shape of the lens leading to pupillary block, buildup of aqueous behind the iris leading to iris bombing, leading to angle closure glaucoma. Please understand this mechanism very well. Predisposing factors, very easy to remember by the mechanism. The factors leading to the changes in the shape and size of the lens, along with the patient having already pre-existing narrow angles, have a predisposition to the angle closure glaucoma. Similarly, as we have discussed pupillary block leading to the mid-dilated pupil, intumescent lens, As we have discussed, AC shallow, raised IOP, narrow angle, and due to the pain and inflammation, corneal edema and circumcorneal congestion. Similarly, in UBM, we will see increased lens thickness, shallow AC in the central, and narrow angle. Patient may not allow gonioscopy, but gonioscopy can be done in fellow eye to assess the status of the angle. ASOCT, increased lens thickness, reduce AC, and narrow angle. We have to understand the differentials and rule out them. Please remember, the mainstay of the management is cataract extraction. Until the time we are preparing the patient for cataract extraction, we have to stabilize the IOP by IOP lowering drugs and PI in the fellow eye to be done. Thank you very much.
Thank you, Manisha. Over to the judges. Can we have any questions?
Phacomorphic glaucoma means your cataract is advancing cataract. It is
Yes.
advanced cataract. So more stress should be given on the management rather than type of glaucomas you earlier mentioned. So you lost lot of time in the earlier slides.
Yes, sir.
So you could not finish and stress on important part of the phacomorphic glaucoma. That was expected. So what precautions you will take while doing surgery on such cases?
So since we are performing the surgery in already patient whose AC is shallow, IOP is raised, we have to first stabilize the IOP. We can do it either by pars plana vitrectomy approach for the phacoemulsification, and we also have to manage that capsular axis may have a high chances of run out in these cases. So again, we have to be very cautious while doing the capsular axis. And sir, in this, since cornea is also compromised, so descemet membrane detachment chances are also there. Our mainstay of the treatment is already we are dealing with a hypermature cataract, which is itself a very difficult surgery. And since here the patient has come with a complication of the hypermature cataract, so we have to stabilize the anterior chamber by maintaining the intraocular pressure. Thank you, sir.
Can we have the marks, please? So calling over the next person is Dr. Devi Karthia from the team Diamond Dazzlers. She is going to talk about newer advances in management of neovascular glaucoma.
Hello. 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 It's on. Hello.
Just raise the volume of this mic, AV visual, guys.
Hello. Are you able to hear now? Yes.
Her name is Dr. Devi Karthia.
Good afternoon, students. Today's class is going to be a case-oriented one and a continuation from yesterday's class. Here comes your first patient. This is an uncontrolled diabetic, and on examination, you are seeing florid neovascularization of the iris and a fundus highly suggestive of PDR. He has got very high IOP. What is it? Anyone? Very good, excellent. Yes, it is NVG. So we will just recapitulate what we learned last class. So in retinal hypoxia, vascular endothelial growth factors are released, causing new vessel formation over the iris, over the angle, increasing the intraocular pressure, and finally causing a synechial angle closure. So what will be the treatment be? We have to treat both the retinal ischemia as well as the rise in the IOP. Laser PRP was and is still remaining as the fundamental treatment modality in NVG. After the introduction of anti-VEGFs, they just revolutionized the treatment of NVG. As you might have guessed now, my topic is newer advances in the management of neovascular glaucoma. Among all these various investigations, OCT angiography is the most recent one. It is non-invasive and it is very helpful in doubtful NVI cases. When you have all these in mind, do not forget the systemic workup in these patients. Hypertensive medications are generally not adequate in cases of advanced NVG. You require surgery. But conventional trabeculectomy has got a very high failure rate. Hence, all these modifications have been made. Among these, anti-VEGFs have been given via different routes and they've helped in better bleb survival. And now, concurrent use of intracameral as well as subconjunctival bevacizumab have been tried. Now, trabeculectomy can become considered as a reliable compass while we navigate the uncharted waters of NVG. Why not switch over to a GPS system? I am talking about aqueous shunts. I am sure you know about the Ahmed valve and the RD implant. Let me tell you the newer ones. We have got Paul glaucoma implant with micro-sized tubules and a novel end plate design. We have Ahmed Clear Path, which is a valve-less one. And also, speaking of compasses, we have iWatch implant, which has got a compass which can externally control the intraocular pressure. Well, here's your second patient with microcystic corneal edema. You manage it medically, and you try to do a gonio. It shows florid NVA, 360-degree peripheral anterior synecdoche, and you are left with no other option other than cyclodestruction. Yes, a sad state for the patient. But recent advances in cycloablation have made promising results in eyes with good vision also. For example, you have got micropulse, transcleral CPC, and instead of laser, you have got high-intensity focused ultrasound, which can be delivered via IOP1 device. Now you may feel well equipped to tackle NVG. Let me just stress the importance of closely monitoring your high-risk patients for the development of NVG. Don't miss out on the latest Journal of IJO Glaucoma edition, March edition for recent advances in NVG. These are the take-home points. Please don't take the notes. I will give you the notes. Don't worry, I'll give you the notes. You can scan this QR code for my personalized handwritten notes, all right? And make sure you read them today itself. Who knows, maybe one among you in this class will make, a groundbreaking treatment paradigm and will make the term 100-day glaucoma an obsolete term in ophthalmology. And I will be so proud as your teacher that day. Thank you so much.
Second real teacher. Congratulations. I don't think we need to ask you any question. Thank you.
Good one.
Okay. Thank you, Devi. So the next participant is Reshika here? Is Nivedha? Okay. So she is number 14 on the list, site squad. She's going to be talking on infantile esotropia.
Good afternoon. Today's class is on infantile esotropia. As we all know, infantile means it's the age between 1 month to 12 months. So the presentation is during the first 6 months of life. And esotropia means inward turning of one or both eyes. It's a concomitant and a non-accommodative type of esotropia. As you guys saw in the previous class of monocular diplopia, where he explained the concept on binocular single vision, that it's based on that. So the etiology of infantile esotropia is unknown. So it's based on two theories, Wirth theory and Chavas theory. Wirth theory is based on sensory phenomenon, which is an irreversible congenital deficit of visual development. The Chavas theory is based on the motor deficit, which is associated with poor fusion. So a good history taking and examination is very important in case of infantile esotropia. The photographs of a child during the initial presentation helps with the onset, duration, and the progression. Examination requires visual acuity and a cycloplegic refraction is a must. Squint evaluation, and in case of an amblyopia, fixation preference should be done using a vertical 10 prism diopter. The clinical features of an infantile esotropia is that there will be more than 30 prism diopter. The extraocular movements will always be full. There will be a hyperopic of between 2 to 3 diopter. There's also an alternate or a cross fixation, which signifies that the vision is equal in both the eyes. So this is an image showing the alternate fixation. This is the right eye fixation to the opposite side. This is the left eye fixation to the other side. This is a video showing a cross fixation where the right eye is fixing to the object on the opposite side. Once it comes to the center, the other eye fixes the object when it moves to the other side. The next, this video shows the fixation preference if amblyopia is present. So the left eye is, both the eyes are fixing to the object. The left eye is the sound eye. Once the object moves to the other eye, there is no abduction of the right eye. Dissociated strabismus, that is the vertical deviation, is done by a cover test. On covering the eye, there is a vertical deviation of the eye upwards. Inferior oblique overaction is done by the extraocular movements. On adduction, there will be an upward movement of the eye, as you can see in this image. Latent nystagmus is present. On occlusion of one eye, there is a nystagmus. On occlusion of one eye, there is a slow nystagmus towards the side of occlusion. So there are some important differential diagnoses that has to be ruled out before we move on to the management. So the two most important differential diagnosis is pseudo-esotropia and accommodative esotropia. In case of pseudo-esotropia, there will be wide nasal bridge with prominent epicanthal folds. In accommodative esotropia, they always respond to a cycloplegic correction, and the hyperopic shift will be of more than 3 diopters. These are the other differential diagnoses that has to be ruled out before we go for a surgical management. And the goal of the management is to correct the deviation and give the best sensory development. Hyperopia of more than 3 diopter, a cycloplegic refraction correction has to be given. What surgery should we go for? Bilateral medial rectus recession is the most preferred surgery, but some surgeons prefer an ipsilateral medial rectus recession with a lateral rectus resection. What is the appropriate age for surgery? There are 2 studies. One is the congenital esotropia observational study, which says that more than 40 prism diopter after 10 weeks of age, surgical management is mandatory. Early versus late infantile strabismus surgery study says that in an early age group, when the surgery is done, there's a better gross stereopsis at 6 years of age. Thank you.
Judges' questions?
How will you measure the visual acuity in infantile age?
So just only fixation can be measured, sir, in an infantile age group. Cardiac acuity. Sorry, sir. Visually evoked VEP is there.
If you can specify age-wise.
More complicated.
In an infantile age group, visual evoked potentials can be done, sir, and after 1 or 2 years, we can do cardiac acuity.
You said you will correct the hypermetropia, associated hypermetropia. How will you know that the hypermetropia is corrected properly? Amplitude of hypermetropia.
Okay. Can we have the marks? So the next participant is anybody present from the team AMC Trios? Okay, what's her name? She is Dr. Divya Shri. She's presenting on blowout fracture of orbit. That's what I was wondering, why are they all present? You can start. She is Dr. Divyashri GN.
Good afternoon, everybody. We are learning about the blowout fracture today. Actually, last class we learned about the you just why is it not playing?
Oh, microvision का quiz.
Okay. Okay, last class we have learnt about the anatomy of orbit. We have all know the anatomy of orbit. In the orbit anatomy, out of the all the way, you can see here, out of all the orbital wall, medial wall and the floor is the most weakest. Lateral wall and the roof are strongest, and orbital rim is strong. So today we learn about orbital floor fracture, blowout fracture. In the mechanism of orbital blowout fracture, where the object of impact, it should be larger than the object of orbital aperture. Where you can see the orbital aperture, the object of impact is larger than that. So where the transfer of, there are two mechanisms, where hydraulic mechanism and buckling mechanism. Where in hydraulic mechanism, here you can see the object of impact is on the orbit, the rim, where the intra-orbital pressure is increased, though the floor gives away. So this is hydraulic mechanism. In buckling mechanism, where the orbit, rim, the object hits the rim, though due to the transfer of force, there is the buckling of the floor. So there is a fracture of the floor. Next, then there is classification. There are pure blowout fracture and impure blowout fracture. In pure blowout fracture, only the orbital wall is involved without involving rim and other facial bones. So in orbital, that pure, there is a trapdoor fracture, which is very, very important. So where there is a fracture segment still attached, there is a entrapment of the muscle. Along with the muscle, there is entrapment of neurovascular bundles. It is most common in pediatric child, where you can see the pediatric, there is no signs of trauma, nothing, it is absolutely white. So this is white eye syndrome, where patient will have oculocardiac reflex, then nausea and bradycardia. Patient will feel nausea, he might have forgotten the injury also. Next, where we have to treat immediately. Next, there is a non-trapdoor fracture, where there is no entrapment, there all the fracture segment, everything perhaps into the antrum. And impure blowout fracture, where all the facial bones and the rim is also involved. Next, then here we learn by case presentation. One, we have a 32-year-old male soldier. He is posted remotely. He suffered injury to his left eye, where he fell on a rock. Then he initially noticed swelling and then redness and pain. And after 1 week, he reached me. And then he noticed asymmetry in the eyes, where you can see the slight subtle asymmetry. Next, then now on the worm's eye view, where you can see a subtle enophthalmos of the left eye. And we confirmed by a ruler method, where it was not 1.5 mm only, not more than 2 mm. Next, then where you can see there is a loss of sensation in the infraorbital and over the cheek. Next, then on extraocular muscle movement, there is a slight restriction in the levo elevation, and there is a diplopia, mild diplopia and upward, extreme upward gaze. Then the force reduction test we do, it is very, very important. It is negative to know the management. Then next, then in ocular examination, his vision is absolutely fine, 6/6. There is no RAPD. It is very important to know, check RAPD. Next, please. Next, and now after the examination, we will come to the investigation. In old days, X-ray was the mainstay. But now we have CT scan, which is got done in bone window, where you can see a teardrop sign here. There and where you can see an entrapment of the muscle also, where you can compare right and left. Right, there is the inferior rectus. The muzzle is not entrapped, but the sheath is entrapped. Okay? So the content has dropped into the antrum. Next. So now what will you do? How will you manage? Here we have the patient, no minimal diplopia, only in the upward gaze, no significant in ophthalmus, no significant hypoglobus. So we went for observation. Next, please. Only observation. But and we asked the patient to avoid the blowing of nose. It is very, very, very important. We have to avoid blowing of nose, and then we gave antibiotic, prophylactic, and decongestant and antihistamines, and to reduce inflammation we give steroids. Next, please. Then what are the indications of surgery when we do it? When we have diplopia and limitation of up gaze or down gaze within 30 degree of primary gaze, and positive force reduction test, and when the radiological confirmation is there and anophthalmus is more than 2 mm. Next, then when we do it, so in pediatric I explained you white eye syndrome, or if it is oculocardiac reflex is not resolving, then you have to do immediately. And if we within 2 weeks we can do mean symptomatic diplopia or large fractures, we can do within 2 weeks. And how to do it? There are surgical approaches. So next, please. Surgical approaches are transorbital, transorbital. Please. Transorbital, there is transconjunctival route, transcutaneous, and cul-de-sac. Next, please.
She has
there
crossed
you can see
4 minutes.
Okay, I think enough. Lot of time. Okay, before.
Okay, sir. Okay. Sir. Transorbital, where you know transcutaneous, conjunctival and cul-de-sac, and transantral and for endoscopic for the posterior floor fractures. And these are the steps where we reduce the fracture, release the entrapped tissue, and reposition the herniated tissue, and repair the post-traumatic. Thank you, sir.
Before question,
Sir.
I will give one advice.
Sir.
Okay? It is very, very important that how much you have to teach. You are pouring so much of the content in a small span of time. Okay?
Sir.
That is not a good teaching. Okay? So, the time and the content, they should match. Okay?
I
So
lost a lot of time in telling them.
Now Hardeep.
Sir.
What is the relation of circumference of the object to cause this fracture, blood fracture?
So it should be the more than
It
orbital
is very important
aperture.
in the
Sir.
history.
Yes, sir.
How injury has happened.
So, we have to ask the patient what is the mode of injury and what the object of injury. When it is a tennis ball, a fist, a rock, which is more than the size of the orbital aperture.
Can football cause orbital fracture and blood fracture?
No, sir. It should be in football. Most of the force taken by the frontal and
In
other
what cases
head.
it can cause?
In tennis ball and
In what cases football can cause blood fracture?
if it is coming from below, sir. If it hits
In
like this.
exophthalmos, patient having very prominent eyes,
Yes, sir.
patient are having very shallow orbits, so they have very prominent eyes, so it can cause. Don't think that it can cause. It should cause.
Sir.
Okay?
Hello.
Marks, please.
I have shown mine.
Yeah, 8, 7.
Till others show, I will like to highlight on some of the mistakes you are doing. See, this is a session dedicated for the teachers of tomorrow. You are going to become not only doctors but teachers as well. And essentially we are going to be a surgeons. Okay. So stress should be given on management part rather than etiology, etiopathogenesis, sign and symptoms, differential diagnosis. It's okay. You are covering all the theoretical part. We can understand as a students, residents, but more stress should be given on the management part.
ठीक है.
And you run out of the time when the last slides management, very important slides come, you run out of the time and everything mess up. So try to focus more on important points of the topic. Make a first slide should be highlight of the content of the your presentation. Got it?
This is a very big topic actually. You should be focused on, practically your topic should be clear. It should be in 3 parts. The whole blood fracture cannot be talked, like symptoms management. In 4 minutes is very less. Either you will be... Yeah.
But you have to cover the salient features.
You have to organize.
And you stress on important points. Like Phakic IOL is a very practical and important topic. But not a single point was mentioned in the how it is implanted, what precautions should be taken, how if it is open upside down, how it should be managed. That was expected in presentation actually.
Sir.
And you are in a competitive session here. I am telling these things for other participants now. See, you are not a consultant where you are asking somebody else to move your slides. So you have been telling next.
Sir, it was malfunctioning, sir, here.
Oh, I see. Okay. Okay.
It-
Then in that case, we'll give it the
malfunctioning.
we'll give the
That's
benefit
why
of doubt.
I
But
lost lot of time
yeah,
in telling them.
yeah. But still you exceeded the time. Anyway, that benefit of doubt will be always given to you. But when you are talking about, as sir said, regarding the management and all, so don't put less time for management. Management has to be given all the importance. It should cover at least 30% of your time in your slides. Okay.
Okay. KA Mumbai, Dr. Bhakti Gade. She's talking on keratoglobus. Okay. Corneal laceration. There's a printing mistake. She's talking on corneal laceration repair.
I'll just run my slides one to make sure that they're...
That's fine. You can start. AV team, please make sure that you mention the timer.
No, audio, just can we see whether that laptop can be changed, because consistently if people are having trouble, it will be difficult for us to give the marks.
Just see if you can run the slides. Okay, you can start.
One second. One second, hold on. This is not my title slide. One second. Yeah, slideshow, please. Yes, sir. Corneal laceration repair. Should I start? Good afternoon, everyone. I'm Dr. Bhakti, and I'll be talking about corneal laceration repair. We've heard of laceration on skin, but what are corneal lacerations? Well, they're basically loss of anatomical continuity of the cornea. We should be studying them as they're commonly seen in our casualties, and as comprehensive ophthalmologists, we must know how to treat such conditions. It's seen commonly in cases of assaults, road traffic accidents, and use of sharp tools in some industries, making it more common in young males as compared to females. We all know the anatomy of cornea, but what we must remember is that a breach beyond the Bowman's membrane heals with scarring. So when a patient of corneal laceration presents to us, we proceed with visual acuity examination in both eyes, followed by thorough anterior and posterior segment examination, with imaging studies required to rule out intraocular foreign body. On the basis of slit lamp examination, the corneal lacerations can be partial thickness, full thickness, corneoscleral, or associated with other complications. The aim of the repair is to restore normal ocular anatomy, to prevent secondary complications, and to maximize visual rehabilitations. Partial thickness corneal lacerations are often self-sealing, which is why they can be treated on an outpatient basis. Sedal testing is done on follow-ups to look for any microscopic leaks, which are repaired by pressure patching and by bandage contact lenses. Full thickness corneal lacerations are open globe injuries requiring surgical intervention. A 10-0 nylon microspatulated reverse cutting suture is taken, as they incite little vascularization and tissue reaction and cause little scarring. The ideal depth of the suture is 90 to 95% of the depth of the stroma, and the sutures taken should be of equal depth and length. And the knots are buried to prevent inflammation. If taken too shallow, they can create internal wound gape. If taken full thickness, they can act as conduit for microbial invasion. Sutures of unequal depth or of unequal length create wound override. A no-touch technique is followed while suturing, where the needle enters the tissue perpendicular and is rotated along the curvature of the needle. To maintain the prolate anatomy of cornea, longer and deeper sutures are taken in the periphery of the cornea, whereas shorter and shallower sutures are taken towards the center. Stellate sutures can be closed by purse ring sutures or bridging sutures. In cases of uveal tissue prolapse, if the presentation is within 24 hours of injury, the tissue can be reposited, whereas if 24 hours have surpassed, it has to be excised. In case of lens capsular tears, the cortical material has to be removed, and cataract formation, if cataract has formed, then it has to be removed in the primary setting. Vitrectomy has to be done for vitreous incarceration, and scleral tears have to be repaired in the primary setting. The use of cyanoacrylate glue can be done to repair small amounts of tissue loss in conjunction with the bandaged contact lenses. Large amounts of tissue loss can be treated with donor graft. The postoperative care is standard with the use of topical antibiotic steroids, cycloplegics and anti-glaucoma medications, and systemic treatment is continued. Suture removal can be done at 1.5 to 3 months, and it depends on patient factors and corneal laceration morphology. Visual rehabilitation is with the use of contact lenses or corrective glasses, and cataract extraction with intraocular lens implantation. The complications include corneal scarring, cataract formation, endophthalmitis, infectious keratitis, post-traumatic glaucoma, and sympathetic ophthalmia, some of which can be really visually impairing. To conclude, early intervention, good suturing skills, and good post-operative care are the pillars of corneal laceration repair. We must remember that prevention is better than cure, and the use of protective eyewear should be advocated in industries which require the use of sharp tools. Thank you.
What are the guidelines for exposed iris tissue?
Sir, if the patient presents to us within 24 hours of the injury, and if the tissue is healthy, we can consider reposition of the tissue. If more than 24 hours have passed and we feel that the tissue is infected, then the tissue has to be excised.
Can we have the marks? So the next speaker has to be ready. The next speaker from the team, Santoshian, who is presenting. Is it Kashi Goyal or Shivangi? Is there anybody? Is there anybody from the team Santoshian? Okay, then we'll move on to the next team. It's VMMC Safdarjung, Delhi. Dr. Hitisha. Yeah, all the best.
Is everybody awake? Yes, ma'am. Good. We'll provide after the class, sir. I'd like to run you all briefly through how to approach a patient of sixth nerve palsy. Let us set some goals for this class. We need to refresh our neuroanatomy about sixth nerve. We need to know what causes sixth nerve palsy, how do we even diagnose this nerve palsy, and what are the important differentials to be considered for sixth nerve palsy. I'm sorry to give you PTSD for refreshing your neuroanatomy, but this is a cross-section of pons. The green structure marked here is the sixth nerve nucleus. Note how the fibers travel anteriorly towards the pontomedullary junction and continue as the sixth nerve. You should note its friends here. The seventh nerve, the eighth nerve, the PPRF, MLF, these are all important and we'll know later why. Now, as it exits from the brain stem, it enters the cavernous sinus after traveling close to the petrous apex. Note its friends within the cavernous sinus. The ICA, the sympathetic plexus, the third, fourth, fifth A and B nerves. From here, it enters our orbit to supply the lateral rectus muscle. Now, let us revise. Where all can the lesions occur? It can be a nuclear lesion, it can be a fascicular lesion, can be a lesion in the subarachnoid space, at the petrous apex, in the cavernous sinus, or at the orbit. Now, what causes a sixth nerve palsy? Now, it will depend whether your presenting patient is a child or an adult. Congenital sixth nerve palsy is relatively rare, so you don't need to stress about it. But in acquired causes, you need to remember there can be head trauma, there can be posterior fossa tumor, or there can be any cause that causes a raised intracranial pressure in the child. Now, in adults, the irony is that the most common cause is idiopathic, but you do not label something as idiopathic till you have investigated everything that you know about. Now, what are the common causes in adults? It can be a microvascular ischemia, head trauma, raised ICP, a pituitary tumor, or a demyelinating lesion of the nerve. How do we know it is sixth nerve palsy? History, history, history. The patient will present with inward deviation of the affected eye and diplopia. What is so fancy about this diplopia? This patient presents with a binocular horizontal diplopia, which is worse for a distant target, and it is worse when the patient tries to see towards the affected side. Always elicit this history. There is some other relevant history that you need to ask, whether there is headache, nausea, weakness of limbs, history of trauma, neurosurgical intervention, or the comorbidities that we already talked about. Coming to the examination. As an ophthalmologist, you need to do a comprehensive ocular examination. There is no shortcut to it. But also at this point, it's nice to have a friend in neurology and ENT because you might need their help in evaluating depending on the history that you have elicited. In ocular examination, best corrected vision is always important. You should note down corneal sensations, you should look at the pupillary reactions, and you have to look at the absence or presence of disc edema. There is no missing disc edema, okay? Then you have to see whether there's a face turn because that would be towards the affected side. Is there associated ptosis or proptosis? There will be a primary position esotropia and there will be limited abduction towards the affected side. Alternate cover test may help you to differentiate between a paralytic and restrictive squint if there's a doubt. Always do diplopia charting because it helps in monitoring the progression in these patients. A forced duction test and active force generation test may help you, depends on the situation. Imaging, blood tests are all dependent on what your history and examination tells you. But early neuroimaging is required in bilateral palsy with neurological symptoms because it can be a false localizing sign. Remember the differentials. It can be a Duane retraction syndrome. It can be infantile ET if it's a child. It can be myasthenia. It can be a MR entrapment. Or it can be a thyroid eye disease if it's an adult. So, I hope you remember the sixth nerve anatomy now. The key to diagnosis is detailed history and examination and always establish a paralytic squint diagnosis. Thank you so much.
Judges' questions? No questions from the judges, so that was a good one. Congratulations, Hitisha. So moving on to the next participant is from the team Vision Wizards, Nagar Koni. She'll be talking on management of pseudophakic bullous keratopathy.
Good morning to all. Today my topic is about management of pseudophakic bullous keratopathy. Now the learning objectives are what is pseudophakic bullous keratopathy and what are all the modes of medical management and modes of surgical management. Now we move on to the pseudophakic bullous keratopathy. Pseudophakic bullous keratopathy is corneal stromal edema mainly post-cataract surgery. The causes are mainly due to surgical trauma to the endothelium. We all know about the endothelial pump mechanism which pushes the water out of the cornea that makes the cornea most transparent. So, in this case of pseudophakic bullous keratopathy, due to the loss of endothelial pump mechanism because of post-trauma due to surgical trauma to the endothelium or else like Fuchs endothelial dystrophy, this occurs, there occurs a stromal edema. The signs will be corneal epithelial and subepithelial bullae, corneal guttate, and the symptoms are poor visual acuity, pain, photophobia, and epiphora. Next, we move on to the topic proper, management, that is medical management. The medical management is topical hyperosmotic agent, pressure lowering agents, and hydrophilic contact lenses, systemic L-cysteine. Surgical management are conjunctival flap, amniotic membrane transplantation, anterior stromal puncture, phototherapeutic keratectomy, deep lamellar endothelial keratoplasty, and corneal transplantation. Now we move on to the medical management, that is topical hyperosmotic agent. This here is a 2 and 5% sodium chloride solution. The main mechanism is it creates a hypertonic tear film that by moving the water out of the cornea. So hence the 5% NaCl ointment is applied at night to the conjunctival cul-de-sac. This is because at the night when we close the eyes, because of the less evaporation of the water from the cornea, the corneal edema tends to be worse at the morning. Hence, to prevent from this, we are using 5% NaCl ointment. Next is a pressure lowering agent. Here is the beta blockers plays the first role. Because of the lowering of the IOP, we can decrease the corneal edema. Next is the hydrophilic contact lenses. Here, the hydrophilic contact lenses is used to decrease the pain because of the rupture of the bullae. The pain in the PBK is mainly due to the rupture of the bullae and exposure of the corneal nerve endings and causes the pain. So it acts as an effective precorneal protective layer. Next is the systemic L-cysteine. The cytokines and the MMPs plays a crucial role in the pathological process of this PBK. Hence, the high level of the L-cysteine may act as a regulatory substrate for MMPs. Next, we move on to the surgical management. The first is the conjunctival flap, Gunderson flap. This creates a local blood supply and promotes a healing and replaces the damaged epithelium. Next is the amniotic membrane transplantation. It is mainly to control the pain in the patients with PBK. This amniotic membrane facilitates a reepithelialization by providing a suitable substrate and normal basement membrane promoting epithelial cell migration and adhesion. The advantage is good pain relief and it is easier to perform and it restores the corneal integrity, epithelial integrity. Next is the anterior stromal puncture in PBK. This is a OPD procedure, effective and low simple cost. Here they use a 20 gauge needle to make multiple shallow penetrations through epithelium into anterior corneal stroma to improve the epithelial adhesion. Corneal transplantation, penetrating keratoplasty is a gold standard. Deep lamellar endothelial keratoplasty. Here the endothelium is replaced with the donor endothelium. Here is a decimal stripping automated endothelial keratoplasty. It's a partial thickness corneal transplant procedure that involves selective removal of patient's decimal membrane and endothelium. Phototherapeutic keratectomy is also a main procedure that involves the ablation of the sensory nerve plexus to prevent the pain. Corneal collagen cross-linking with riboflavin is a photochemical process, is now considered a new tool in temporary reduction of the corneal edema in PBK. Thank you.
It was a good elaborated lecture. Suppose you are in tertiary center.
Yes, sir.
After doing all medical management, what will be your first choice of surgery? In case you want to do surgery, what will be the first surgery and final?
The latest management is DSEC, so I will prefer.
Good one. But in your presentation, you mentioned about DALK.
Sir?
DALK. Deep lamellar anterior keratoplasty. You mentioned.
Yes, sir.
How it will help to treat the bullous keratopathy?
How, sir?
How DALK will help to resolve the bullous keratopathy? Where the pathophysiology is related to the endothelial problem. You have mentioned DALK in the treatment.
Deep lamellar endothelial keratoplasty, DLEK. Yes, sir. Thank you.
Okay, can we have the marks? 8. 9 or 6? 9. Okay. So the next participant is Dr. Twisha Tandil. She's from the team Baroda Beacons. She's speaking on macular function tests. Panch. Macular function tests.
Good afternoon, everyone. What a lovely looking audience. And definitely, my macula is helping me to visualize this. Like sun, which plays center part of our solar system, this center part of our retina contains only 6 layers and yet most sensitive structure of our eye. So presenting you the mac of macula. It gives us sight so specular. It gives us central vision, color and clarity. It gives us most of what we see. With this background in our mind, let us proceed towards classification of macular function test. It is classified as MFT with clear media and MFT with opaque media, and these are the tests. As we saw that macula is responsible for most of our central vision, and pinhole helps to focus light rays over macula by inhibiting peripheral rays. So, in the patients with pinhole, in the patients with macular diseases, vision deteriorates with pinhole. Here vision is taken on the Snellen's chart. Other Snellen's chart, which is reduced Snellen's chart, is used by this device known as potential acuity meter. Here we can assess macular function in opaque media also, as is directly projecting reduced Snellen's chart over macula. Our macula is packed with lots of cones, and hence it gives sharp color tones. So what if our cones are not supporting? In patients with macular diseases, color blindness is seen, and most common color blindness is seen is retinopathy, which is blue-yellow defect. And Ishihara chart is used to test color vision. One of my patients named Mukesh came to me for routine screening. So I gave him Amsler's grid to test his macular function. It is done uniocularly at a normal reading distance. And we asked the patient to focus on the center spot. And then we asked if any straight lines are looking wavy, or any dark spot seen in front of these grid lines, or any missing grid lines are seen. If the answer is yes, then he may have macular dysfunction. Now this patient Mukesh came back to me after 6 months. At this time, he has immature senile cataract. Therefore, this time I gave him Maddox rod. It is used in, to assess macular function in opaque media. Here, high power cylindrical lens are used, which converts point source of light into straight vertical or horizontal line. Any distortion or holes in this line causes suggesting of macular dysfunction. Our visual pigments bleached by the bright source of light, and it causes temporary retinal insensitivity, which is perceived by patient as scotoma. This principle is used by this stress photostress test. Recovery time increases in the macular diseases. These are some other tests used to, for macular function. Thank you.
What is the difference between human eye and eagle's eye? Why eagle can see from too far? Not related to your topic.
This is very good question. I'll come back to you in next class.
Well answered.
Very well answered.
It has two maculas.
Okay.
Can we have the marks? So the next participant is from the team Mata Gujri Devi Memorial. The contestant is Anirudh Mazumdar. Is he here? Dr. Rajnita Basur? Nobody? So the next team is IGIMS Patna. Dr. Preeti Sinha. She is talking on glaucoma drainage devices. Can we have the pointer to change to be able to change the slide?
So good afternoon, judges and my dear students. Today I am here to discuss about glaucoma drainage devices. But before that, I would like to ask, what is the procedure of choice for a glaucoma filtration surgery? Well, for the past 25 to 30 years, it has been trabeculectomy. Then why do we need to look for other options? Well, basically because despite the various modifications in the suture techniques, the flow control has remained an issue. And also in 20% of cases, conventional trap fails. So the glaucoma drainage devices offers a very good alternative. Now, further, how it all started. So let me take you through a short history. In 1907, Rowlett actually used a horsehair. It is not working. Rowlett actually used a horsehair to drain hypopyon in a case of corneal ulcer. Later, Zorab used this same technique in 2 patients of neovascular glaucoma. It is not working. So, later Zorab used the same technique in 2 patients of neovascular glaucoma, and the whole idea of GDD was revolutionized when Molteno used a tube and an implant and a plate, and that was a yardstick milestone in the development of GDD. So now coming to GDD, it can be valved, non-valved or shunts, but today I will be discussing about valved and non-valved devices. Among the non-valved are the Molteno, bare valve, Adi, and among the valved is the most popular Ahmad glaucoma valve. So this is the Molteno implant, single plate and dual plate, and this is the bare valve implant, which is single plate fenestrated and comes in two sizes, 250 and 350 millimeters square. And this is the Ahmad glaucoma valve, which has a tube and a plate, and this is the valve, and it acts on a principle of Venturi. So it has a preset pressure, and after which if the IOP rises, it opens up and aqueous starts flowing in unidirectional. Now, how it is implanted? First, after a block, a subconjunctival space is created, and the plate is implanted between the superior rectus and the inferior rectus, and then is sutured, and then the tube is cut with a beveled edge, and the track is created using a 23 and 22 gauge needle, and the tube is implanted into the anterior chamber. So how this whole mechanism works? After the insertion of the plate, a collagenous capsule forms around it, and there is a granulomatous reaction, which usually resolves in 4 months, and it becomes stable after 6 months, and a filtering bleb forms. So we have to continue anti-glaucoma medications in patients of GDD. So who are the patients eligible for a drainage device? Well, all the patients with previously failed trap, conjunctival scarring, and cases of complicated glaucomas are the GDD are the preferred choice. So no surgery is without complications. Beside the usual complications, the specific ones are the tube misdirection, tube extrusion, migration. These are the pictures showing conjunctival exposure, tube migration anteriorly, and the bleb encapsulation. Now, no talk is complete without discussing the studies. The two landmark studies are the tube versus trap study and the Ahmad bare valve comparison study. So to conclude, I would say that GDD forms an important armamentarium against our fight with glaucoma. To ensure good surgical outcome, proper selection of patient and device is very important, as well as proper counseling of the patient is very crucial, as these patients require multiple follow-ups. Thank you.
Thank you. Questions?
What is very important part of the implantation of glaucoma, especially Ahmad glaucoma valve? How do you ensure? How will you ensure that it is not going to expose in the future?
Sir,
that is the most important thing.
Yes, sir. First, we have to.
For any.
Yes, sir. Pre-op evaluation is very crucial. We should include the conjunctival motility and locate the areas of conjunctival scarring, and also the anterior chamber depth and the lenticular status. And after the implantation of the plate and the tube is covered with a scleral patch graft or any donor pericardium.
Suppose conjunctiva is less.
Yes, sir.
Because many times you may find a cases of post-RD and like that.
Yes,
a lot of conjunctival scarring is already there.
Yes, sir.
So how will it ensure that this is not going to expose?
Sir, we planned the GDD, most common preferred place is the superiotemporal. Then in cases of RD or where there is silicon oil, we place it in the inferotemporal quadrant and cover it with this scleral patch graft, sir.
Hello.
Good afternoon. I am Shreya from Team AMEA with my co-presenter Dr. Monica and my mentor Dr. Tony, and we are from Arvind Eye Hospital, Madurai. Imagine a patient comes to your OPD with complaints of defective vision. On examining, you find a corneal ulcer. Won't you be surprised? Yeah, that patient
has an absolutely painless corneal ulcer. So welcome to neurotrophic keratitis. It's a degenerative disease of corneal epithelium characterized by impaired healing, usually secondary to a damaged or a dysfunctional trigeminal nerve. So the absence of corneal sensitivity is the hallmark. In our cornea, we have nerves and epithelial cells which support each other via neurotrophic and epitheliotropic factors. So if there is any imbalance, there occurs our pathology. So looking at causes of corneal hyperesthesia, it can be secondary to infections like herpes zoster, herpes simplex, could be a frank fifth nerve palsy, systemic causes like diabetes, iatrogenic due to contact lens wear, topical medication abuse like anesthetics, and many other causes are documented. As I've already explained to you about the interaction between corneal nerves and epithelial cells, going on to pathology, we have a decrease in epitheliotropic factors which leads to poor renewal of epithelial cells causing non-healing epithelial defects which causes neurotrophic keratitis. There is a decrease in corneal sensation causing the person's cornea prone to occult injury. The person won't even know and injuries will be occurring. This will again lead to neurotrophic keratitis. Coming on to evaluation, we have to pay utmost importance to history. We have to look for causes of corneal anesthesia. We have to do a thorough cranial nerve examination and we have to pay attention to corneal sensations. That is checked via a cotton wisp and a Cauchet bonnet aesthesiometer. We have to do a thorough ocular examination via slit lamp to grade the disease and for further treatment. We can even do corneal scrapings and culture to look for infective causes. So to make things easier, we have staged this disease into 1, 2, and 3. We have P's, punctate epithelial erosions in stage 1. When they coalesce together, we get bigger epithelial defects in stage 2 along with cells and flare. In stage 3, we can have stromal lysis, which can lead to corneal perforations. Management is for the stage 1 and stage 2, we have quite similar protocols. We can use topical preservative-free lubricants. We can even use autologous serums, 20% in concentration. And we have newer agents like cenegermin, which is a recombinant nerve growth factor. We can even do a tarsorrhaphy for stage 2. Stage 3 involves prevention of impending perforation or treating an already happened corneal perforation. So for impending perforations, we have cyanoacrylate glue, bandage contact lens. We can do a tectonic lamellar keratoplasty, which is obviously superior to penetrating keratoplasty. And we can even do amniotic membrane transplants. Similar protocols are followed for corneal perforations. I would like to stress upon something which is very new. What if you could treat the root cause? So you could regenerate the nerve supply to the affected limbus. It can be done via sural nerve graft, which is indirect neurotization, or you could do a direct neurotization through the already present supraorbital and supratrochlear nerves. So my take-home message is, if you find any patient in your OPD with an ulcer and no pain, do not ignore. Check for corneal sensations and treat accordingly. Thank you.
Thank you, Dr. Shreya. Please tell me, you have less stressed, actually, although you have shown the video, where to touch the cotton wood to check the cotton wish to test the corneal sensation. What the point of touching? That is very, very important, because that only will decide that whether it is neurotropic or not.
So I think it's the inferotemporal cornea that we check.
Huh?
The inferotemporal area in the cornea.
Which is the more sensitive area.
Suppose you are touching on the cornea which is keratinized, then what will happen? Because where you are touching your cotton which you are touching, it was on the scar.
You have to touch on the cornea which is normal. Thank you.
Good evening, class. I am Dr. Tilottama, and today we are going to discuss about pupillary pathway and its abnormalities. I know it has already been a very long day, but this usually comes as a long question with diagrams, so paying attention would be helpful. First is a light reflex. It consists of the direct light reflex and the consensual light reflex. Constriction of the pupil in which the light is shown is the direct light reflex, and simultaneous constriction of the other pupil is consensual light reflex. It's a light pathway. It starts from the impulses which are generated in the photoreceptor cells in the retina and travels all the way along the optic nerve, optic chiasma, optic tract to the ipsilateral pretectal nucleus. From there, the internuntial fibers supply the bilateral Edinger-Westphal nucleus. This forms the basis of the consensual light reflex. The efferent pathway from the Edinger-Westphal nucleus travel along the oculomotor nerve and relay in the ciliary ganglion. From there, the short posterior ciliary nerves innervate the sphincter pupillary muscle, which causes pupillary constriction. The near reflex consists of the convergence reflex and the accommodation reflex. There is constriction of the pupil, increased accommodation, and convergence of the visual axis. The convergence reflex pathway is not very well elucidated. The efferent pathway starts from the medial rectus muscle, goes along up to the convergence center. The internuntial fibers supply the Edinger-Westphal nucleus, and the efferent pathway along the oculomotor nerve relay in the accessory ganglion and supply the sphincter pupillary muscle. The accommodation reflex pathway starts from the retina and goes all the way up to the pyostriate cortex via the optic nerve, optic chiasma, optic tract, and the internuntial fibers supply the bilateral Edinger-Westphal nucleus via this occipital mesencephalic tract. And the efferent pathway along the oculomotor nerve supply the both accessory ganglion and the ciliary ganglion and innervate the ciliary muscle and the sphincter pupillary muscle. Now coming to the afferent pupillary defects, in this both the pupils are usually normal in size. The total afferent pupillary defect, also known as the amaurotic pupil, there is no light perception in the affected eye. When light is shown on the normal eye, there is constriction of both the pupils, and when light is shown on the affected eye, there is dilatation of both the pupils. The relative afferent pupillary defect, also known as a Marcus-Kern pupil, there is a paradoxical pupillary response. When light is shown on the affected eye, there is paradoxical dilatation. When light is shown in the normal eye, which is the left eye, there is constriction of the pupil. And this can only be elucidated in unilateral optic pathway lesions. Next is the efferent pathway defects, usually present with anisocoria. The most common cause being the oculomotor nerve palsy. Compressive lesions of the oculomotor nerve usually has pupillary involvement. The pupillary light near dissociation, in which the light reflex is present and the light reflex is absent and the near reflex is present. These are the various levels at which the lesion can occur. The idiopathic Tony's addict pupil occurs due to lesions in the ciliary ganglion. There is sectoral iris palsy, which causes vermiform movement of the pupillary margins, and it can be diagnosed with diluted pilocarpine. The Arjen-Robertson pupil, as the name suggests, ARP, which stands for accommodation reflex present, seen in tertiary syphilis, the patient usually has a good vision. There is loss of light reflex, but accommodation reflex persists as shown in the video. So coming to the end of the class, thank you.
Can you give me a clinical condition where accommodation reflex is present and light reflex is absent?
Arjen-Robertson pupil and also sir, it can occur in case of bilateral optic atrophy if there is total retinal detachment.
Such a clinical condition doesn't exist. That's why I asked you this question. So when you remember ARP, right? Accommodation reflex present. Argyll-Robertson pupil. But converse is not true. There is no clinical condition at all where there is accommodation reflex present but light reflex is absent.
Can we have the marks? 7, 8. Okay, so the second last participant, Dr. Reshma. Is Dr. Ravi Kumar here? Anybody from AIMS Patna? You are here? Okay, just give me a moment, sorry. So you have to present. Who, Dr. Kopal. She's talking on recent advances of amblyopia therapy. So we have the last two. Sorry for keeping you all waiting. The last two. Then we'll tally the marks and tell you all.
Good evening, everyone. We are going to discuss recent advances in amblyopia therapy. It is a disorder of visual acuity, as we all know, and it can present as unilateral and bilateral presentation. In children, it has a prevalence up to 1 to 6%. In management part, we know two types of management, that is conventional and non-conventional. Refractive correction and occlusion are most common treatment part of the conventional treatment. In non-conventional, binocular stimulation is the most important criteria, and it includes perceptual learning, dioptic therapy, visual reality, as well as orthoptic treatment management. Refractive correction is the most common and important in all age group of the patient, and occlusion, if refractive correction is not improved then patching is preferred. So, as we all know, in amblyopic patients, loss of binocularity and stereopsis is common. So, to provide the treatment, we use binocular stimulation. In binocular stimulation, perceptual learning, dioptic training, virtual reality, and orthoptic magnocellular stimulator is used. In perceptual learning, it is based on the criteria of practice makes man perfect. So, a child with amblyopia, full optical correction is given, and sound eye is occluded, and amblyopic eye is given as a definite stimuli that includes vernier acuity, contrast based, and Gabus patches. So, repeated activity is given on the basis of this, and it influences neural plasticity. OE et al. Described a term push and pull protocol, in which the sound eye is given inhibitory stimulus, as well as amblyopic eye is given excitatory stimulus, which can lead to binocular stimulation. The limitation of perceptual learning is mostly limited visual tasks, as well as lack of home-based strategies. Further, we will move to dioptic training. In dioptic training, a patient is provided anaglyphic glasses, in which high contrast images is provided to amblyopic eye, and low contrast images is provided to sound eye. And in this, it is used to overcome interocular suppression. The patient is given falling block games, in which red is of high contrast and blue is of low contrast. Bravo study is done to compare the efficacy of binocular video game with placebo video games, and at the end of 6 weeks, it did not show any improvement by both of this. Herpetic conducted a first large-scale study to compare the binocular gameplay with patching, and at the end of 16 weeks, it shows similar improvement, but the loss was that 13% of participants only completed the treatment. Further, dig rush game was invented, and it is showed contrast rebalance dioptic game, which include high contrast element, reduced contrast element, as well as high contrast background elements. In the previous treatment, we saw that we only provided 2D environment, but in virtual reality, we provided 3D environment, and patient was given 3D head mount devices, and similar images was provided to both eyes with some dissimilarity of contrast, and the patient was asked to fuse the image. The key element was only shown to amblyopic eyes. Further, orthoptic magnocellular stimulator. In amblyopic eye, there is attention deficiency, so orthoptic magnocellular stimulator is used to affect that part of the treatment. Amblyopia is so in newer advances, we want to treat the binocular stimulation, and newer treatment focuses on the binocular stimulation by working on neural plasticity. Thank you.
Thank you.
Very good.
Yes, sir. Sorry, sir. third year. Sir, we usually, if an amblyopic child present to our OPD, first of all, we will go for refractive correction or retinoscopy under cycloplegics. We will prescribe full refraction, full
No.
cycloplegic refraction.
See what he is asking. We are concentrating only on amblyopia. Okay? We are concentrating only on amblyopia. Okay? If amblyopia, a child coming from a village and his or her father, mother, they cannot regularly come to the hospital. So what amblyopic therapy you are going to suggest for him at home?
So we used refractive correction with patching or occlusion. Patching.
Occlusion is one.
Yes, sir.
Next.
Sir, then we can go for optical penalization.
Okay.
In my institute, we usually prefer
Have
these
you
two.
tried penalization?
Sir, in later on age group, that 8 to 9 years of patients which are not completely.
Yes or no?
Don't talk theory. You already.
Yeah. Yes or no?
Yes, sir. In that age group, we had used with cyclopentolate. So we had used this much.
See, your topic is recent advance in management of amblyopia.
Yes, sir.
I want to know what are the modalities you have used in even clinical practice. You have third year student.
Very important.
I got during your presentation is you are talking theory rather than practice. You should walk your talk. That is what I mean to say. It is very difficult at this age, but whatever you do in your day-to-day OPD, try and give best possible things to the patient. So occlusion is the best modality of treatment in amblyopia. You have mentioned a whole lot of things, but practically they are not possible. Occlusion is very much possible.
The most important and treatable condition.
Good evening, everyone. So today I'll be talking about evaluation and management of macular hole. So what is macular hole? So it is a full thickness foveal retinal defect starting from the internal limiting membrane up till the outer photoreceptor layer. And according to literature, the most common cause is actually idiopathic. So what symptoms will the patient present to you with? They will present to you with three main symptoms: central vision loss, metamorphopsia, and central scotoma. So how will we evaluate the patient? We can evaluate the patient firstly a thorough history, including the onset of symptoms and duration since onset of symptoms and any preceding events like trauma. And further, fundus evaluation is vital. So in the fundus, what will you see? So you'll see a reddish circumscribed lesion at the fovea. And we can also do a 90D biomicroscopy, place a beam of light onto the area of defect, and you'll probably see the light going inward, suggesting a defect. So with this, we can actually do a test, the Vatsky-Allen test. So wherein when you apply this slit beam of light onto the defect, you ask the patient if they have any discontinuity in the line. So if there's a discontinuity, then they may have a macular hole. Further, we can also project a photocoagulator aiming beam within the lesion. And if the patient has a hole, they may not detect the same, but around the hole, they'll be able to detect the light. And another test which we can do is Amsler grid, wherein we can detect the photometamorphopsia and also sometimes central scotoma. But none of these are diagnostic. So the diagnostic test is always OCT. So why is OCT gold standard? Because as I mentioned, we should know if it's a full thickness macular hole. So OCT will be able to tell us if it's from the internal limiting membrane up till the photoreceptor if there's a defect. Further, with OCT, we can also do macular hole indices. So that will actually help us prognosticate after surgery the outcome. And most important being macular hole index and hole form factor. So another main thing is we have to differentiate macular hole from two entities. One is lamellar macular hole, so wherein actually there is a defect, but the photoreceptor layer is intact. So then it's not a full thickness macular hole. Also pseudomacular hole where the neurosensory layer is intact, but there's a ERM which is giving away in the center. So now, once we have diagnosed, now we have to classify because we have to further manage the patient. So classification, there's an older classification, gas classification. It's based on fundus examination findings. So we'll be looking into the newer classification, the International Vitreomacular Fraction Study. So there, actually we divide the macular hole into based on the size and presence or absence of vitreomacular adhesion and traction. So this is the OCT imaging. And further, we plan for management based on this imaging. And so if the patient actually has a small to medium sized hole and is asymptomatic, we just observe the patient. But if they're symptomatic, then we have to go for a surgical management, which will be pars plana vitrectomy. So the aim of the management is to relieve traction, that is tangential traction and anterior posterior vitreomacular traction. So like I said, so if we go in for a surgical technique, so a surgical technique includes, so I'll just go through the main steps. One is induction of PVD, wherein we are relieving the anterior posterior traction, injection of vital stain and staining the ILM or ERM to enable peeling. And macular excess, again we will remove the tangential traction and further followed by endotamponade to help the macular edges oppose. And further post-op, we ask the patient to be face down for a week and serially be monitored with fundoscopy and OCT. A variation of surgical technique can be an inverse flap technique for larger macular holes, wherein we leave one part intact of the ILM and then stuff it into the macular hole. So take-home points are the most common cause is idiopathic, gold standard is OCT, IVTS classification is used, and treatment option is observation and surgical intervention. Aim of surgical intervention to relieve traction. Thank you.
If you have a patient of partial thickness macular hole, will you treat it?
It depends on if the patient is symptomatic or not. We can observe it. Oh.
I have given the diagnosis, partial thickness macular hole. Okay. Will you treat it surgically or not?
Depending on the visual acuity.
Partial thickness macular hole.
It's not
nothing else.
Okay.
I have given diagnosis. Will you treat or not? Yes or no?
No.
What is the answer?
No.
Why no? You mentioned the answer in your PPT. Will you forward?
Okay.
Come on. Okay, it's okay.
Can we have the marks? So the last participant was Sai Tejasvi. She had presented first. So we'll just finish. And the marks will be discussed with the judges. We had a lot of participants today, a lot of tie-ups. So we'll just discuss with all the judges and we'll put up the marks on the group. Exactly in half an hour's time. From here you can directly move to the microvision quiz.
Yes, sir. Approach to a case of dyschedema. I am number 4 on the list.
First page, 6th one.
Approach to a case of dyschedema.
Yes. Good evening to everyone present here. My topic is an approach.
Don't worry, you have got one more chance. Don't look at the chairs, look at the judges.
To a case of dyschedema, and we are team Retinopathy. Certain terminologies exist in dyschedema. One is true dyschedema and another is pseudo dyschedema. Under true dyschedema, we have papilledema, which is due to raised intracranial pressure, and dyschedema, which is due to causes other than raised intracranial pressure, and pseudo dyschedema, which is causes due to which is not due to accident swelling. So I have 4 steps to approach to a case of dyschedema. Step number 1 is to identify whether it's a true dyschedema or a pseudo dyschedema. So true dyschedema has certain features. We have 5 mechanical signs and 5 vascular signs. So mechanical signs will include elevation of the optic disc, blurring of the disc margins, filling in of the optic cup, edema of the RNFL and folds. And vascular signs will include hyperemia of the disc, venous congestion, peripapillary hemorrhages, exudates, and nerve fiber layer influx. Whereas pseudo-disc edema will have a contrasting picture in the form of a yellow disc, sharp optic disc margins, no cup, no retinal or choroidal folds, presence of SVPs, normal vessels, no telangiectatic vessels, transparent RNFL and absent RNFL hemorrhages. And it is usually bilateral in presentation. We'll put away pseudo-disc edema first. So the most common cause is optic disc drusen, which has a lumpy, bumpy appearance on the OCT. Tilted disc anomaly is another cause. Other causes include morning glory syndrome, myelinated nerve fiber layers, Burgmeister papilla, optic disc hypoplasia, congenital crowded disc, and BPT. So step number 2, once you identify a disc edema, next is to go into the history, do a BCVA, check for RAPD, color vision, blood pressure, fundus for any other etiological clues, visual fields, and OCT ONH to confirm a diagnosis, and do not forget to examine the other eye. So step number 3 is to establish whether it is a unilateral disc edema or a bilateral disc edema. So some causes of unilateral disc edema will include non-arteritic AION, arteritic AION, optic neuritis, CRVO. Rare causes will include compressive optic neuropathy secondary to a tumor, infiltrative optic neuropathy in leukemias, neuroretinitis, and ocular hypertony post-trap. So bilateral disc edema causes will include most important papilledema, hypertensive retinopathy, diabetic papillopathy where a DR may not coexist, and toxic optic neuropathy. So step number 4, once you have established a bilateral disc edema, is to rule out a papilledema, which is a neuro-ophthalmic emergency. So some signs which will help us will include headache, TIAs, double vision, pulsatile tinnitus where the patient hears his own heartbeat, nausea and vomiting. Signs will include disc edema, enlarged blind spot, retinal hemorrhages, and impaired lateral gaze due to abducens palsy. So intracranial causes of papilledema will include IIH, where neuroimaging, everything is normal, just that the elevated lumbar puncture pressure, ICSOLs, which are space-occupying lesions, intracranial infections, and last will be venous sinus thrombosis. Some systemic causes also exist, which includes medications, obstructive sleep apnea, polycystic ovarian disease, and microcystic anemia. So step number 5, let us put what knowledge we have gained to the test. So I have a patient, 35-year-old female, who had a recent vein gain. Everything is normal. You go see the disc has a bilateral disc edema. You check the BP, it's normal. Visual fields are normal, but the CSF opening pressure is high. So the diagnosis is a case of IIH. So example number 2, we have a 38-year-old female with sudden loss of vision with a painful eye movement as the only history. RAPD and color vision is impaired. And they have a unilateral disc edema. BP is normal, and MRI shows an increased contrast sensitivity in the right eye. Diagnosis will be optic neuritis. Okay. So the third example, it's a 64-year-old male who is a known diabetic. Everything is sluggish. You get this picture, you run and check the BP, it is elevated, so it is a grade 4 hypertensive retinopathy. So to conclude, I'd like to put forward 3 important things that you need to do when you see a case of disc edema, which is to check the pupils, check the color vision, and check the blood pressure. Thank you.
She has answered everything.
Question पूछो?
Sure, sir.
This is not related to disc edema.
Sure. Okay. I'll try my best. Yes, sir.
Non-visible edema, that is retrobulbar neuritis.
Yes,
How
sir.
will you treat?
How? Retrobulbar neuritis.
Modalities of treatment. 1, 2, 3.
Steroids. Steroids. No.
Steroid is a very big term. How?
You are asking what names?
No, not. I don't remember.
Steroid is partially correct.
Pulse therapy of prednisone.
Yes, sir.
Prednisone.
Yes, sir. IVM. Pulse therapy of methylprednisolone. Yes, sir.
IV.
Yes, sir.
Oral.
Yes, sir.
And
No.
retrobulbar depot preparation.
Okay. Yes,
will
sir.
help with less side effects.
Yes, sir. Yes, sir.
So targeted treatment, Cargill treatment. Retrobulbar tricot can help resolve the Cargill.
Thank you. Thank you, sir.